morning, everybody. See, so, am I audible there? See, this, I think this is my first, class in medical office Calicut, even though I was associated with other entrance classes here in Calicut also. I think I take class, ophthalmology entrance classes almost everywhere in Kerala, and also in some neighboring states like Tamil Nadu, Chennai and Bangalore. So, I had the luck to be associated with the question pools of the various entrance exams, including the oral examination. So I have a, fair idea about how the questions come and all. See, we had, some of you may have written in the last AIMS entrance exam, and you must have noticed that there were 16 ophthalmology questions, and in fact we were able to predict, we had a discussion of 12 out of, and none of these questions were, previously asked, but we were able to discuss, we were able to have a discussion, around 12 of that question. So that is not bad. So, and many of our students have been having very good rank in institute exams. So my questions are primarily based on the institute examination question. So my questions are primarily based on it, even though we will discuss state entrance exam questions. It's not my aim to make you study whatever MCQs I have given. It's not my aim. My aim, I will be discussing on all of the questions which are asked in the last 7 or 8 years from that area. So you know that the entrance exam questions repeatedly come from the same area. It's not like that it comes from entire textbook. It comes from almost the same areas. So that is why the people who prepare back-referring questions have, you may have noticed, they score very high ranks. Rather than a person who has studied everything, every book, and then, go for entrance exam, they may still score marks, but the person who has back-referred the questions will definitely be at a higher rank than others. This is because question repeatedly comes from the same area. I already told you I had the luck to be associated with the question pool of the All India entrance examination of a few years back. So there will be specific instruction given to the question setter. They will tell some of these questions, percentage of this question should come from these areas. That means it will cover the most important areas. And they will tell you 20% of the question should be very, very difficult. So definitely that means there are certain areas prescribed by the exam conducting body to the examiner to put questions. That is why I told you questions repeatedly come from same areas. If you see the last All India, AIMS exam, there were 16 ophthalmology MCQs, there were only 17 medicine questions. So that is the, importance for an institute entrance exam. It may not be right for the Kerala state entrance exam. And I also want to tell you the high rankers or the high scoring students are never been very good students of the MBBS course. It's not my aim to discourage any of the high ranking students in this class. My only aim is to encourage the majority of the students who are very average, who are like me, and I have never been, the first theory exam that I passed was the first MBBS university exam, so, but I could get through all the entrance exams, including the AIMS entrance exam with, good rank. So it is, my only aim is to encourage the students who are average. And I have given you a tip, you have to read, repeatedly read STEAM areas. You understood? So we back referring a question, back referring the textbook from a question will be the best approach to for very high rank. And as you know, the majority of the question setters of this, institutes, of this entrance exam of the various medical colleges, and except AIIMS entrance exam, all other institutes will invite questions from other faculties. So the main question setters, as you know, come from 5 major institutes in the country: AIIMS, PGI, TMC Vellore, KMC Manipal, and till last year it was St. John's Medical College, Bangalore. So these contribute the main All India entrance exam questions till last year. So they may change it periodically, but they were. So the problem with these, many of these institutes are very leading institutes in the country. So their undergraduate will see what we may not see in ophthalmology in our medical colleges. So, for example, a question from sickle cell retinopathy is a very common thing in Delhi. So an undergraduate will naturally see at least the photographs or the fluorescent angiograph pictures. It's very common for them, but it is not common for our students. Moreover, our exposure as an undergraduate in ophthalmology is also poor. Half of the classes we will not go, and moreover, probably the teachers also will not bring you to that level. They will just show you. They may probably, none of you may have seen through a slit lamp, may not have used a direct ophthalmoscope, but these are all done in institutes, an undergraduate institute. So our aim is to tackle these questions. And I was also a teacher in a medical college, in Trivandrum, Regional Institute of Ophthalmology in Trivandrum. But that is only for 2 years. I was primarily associated with one of the top institutes in the country where I was working from 2000 to 2008, and again I am still back there in the Aravind Eye Hospitals in Madurai. So, and I am very happy that 2 of our students have been selected there also last year for an MS course. That is probably one of the best courses in the country as an ophthalmologist. So there are opportunities like institutes will be conducting entrance exam. You may not be probably knowing it. So there are open entrance exams, and only very good. They not only assess your entrance exam, but also assess your interest in the specialty by posting you there for 1 or 2 weeks, and then so 2 of the students from Trivandrum and 1 from Thrissur got MS exam, MS in Aravind, and that is like a fee, it's like a government fee. It's purely an all India entrance exam. So there are opportunities, and there are DNB students there. DNB students. The pass percentage of the DNB there is almost 100% because they are taught extensively, and you will be a complete postgraduate. So that is other opportunities of it. There are institutes like this, you should not miss it. Not only All India, Kerala and major institutes, there are other institutes where they are conducting classes, conducting these courses. So with that we will go into these questions. I will be going and discussing each question and will go around that question. That is my aim, and we will discuss all other questions. I will tell you to take down certain things, that things you have to take down and read before the exam. And I don't go through just question and answer type. I will always want an active participation from you. So that is the only way we can go up. And I don't mind, see, this, you really have to answer. You will probably go wrong in your answer. That embarrassment of answering and going wrong in an open class will make you remember this. Probably I don't want to tell you that you remember throughout your lifetime, probably for 1 year, not more than that. Okay, with that we will go ahead. And I told you the questions are primarily based on the AIIMS entrance exam. So the questions will be tough, and these are questions which have come over the previous years, and we will just go about and discuss the other questions which is asked in names from PGI, from all other major institutes and the state entrance exam. This is the way we go ahead. And whatever I tell, you have to take down. That will be there. That will be the points which are not covered in the MCQs, but will be extra that I will be telling. You just have to take down when I tell. Otherwise, you have to listen. You also have to get to know that last year there was a change by the government of India to put an entrance exam for the entire institutes in the country, one entrance exam, and the entrance exam pattern also came. Actually 40% of the question has to be clinical questions, clinical photographs, clinical science, patient histories, etc. So there are clinical anatomies like that only, not a pure theory question. But last year it was they were planning to introduce for the last entrance exam, all India entrance exam, to cover entire institutes in the country. But probably because of the lack of time, the questions could not be pooled, and so probably it was abandoned. We don't know whether that will come. Such questions will come in the next entrance exam. But I have just included some of the photographs to just get familiarized with you. So the point I want to tell you, whenever you read, better look at the clinical pictures, clinical photographs, histopathology pictures, radiographs, etc. Okay? Because there was a move, and I actually got the communication also, but it was not introduced because of probably the lack of time. So we don't know whether it will be introduced. One entrance exam for the entire country, and with 40% question as clinical questions, clinical photographs, clinical histories, radiographs, etc. So that is also you have to prepare. When you have to look at the histopathology pictures, when you prepare everything, you have to calculate. It may come. We don't know now. With that, we will go into the first question, which is not true regarding hypertension and eye. It can produce superficial retinal hemorrhages, hard exudate, soft exudate, cannot produce disc edema. So what is the answer? Yes, cannot produce disc edema. That is what the answer given by some of you. So when it produces disc edema, what we call as accelerated or a malignant hypertension. So this question has been asked in a different way. When the diastolic BP goes above, okay, we will find out. Your answer is on 10, we will find out. Okay. So when there is hypertensive retinopathy with disc edema, that is grade 4 hypertensive retinopathy. That is grade 4 hypertension. See, the other MCQ that has been asked from this area is, you all know that hypertension produces hemorrhage, Cottonwool spots, soft exudates, hard exudates, everything. But hypertension can produce only disc edema without any other finding of hypertensive retinopathy. So that particular fact was asked on such MCQ. Hypertension can produce bilateral disc edema without any other finding of hypertensive retinopathy. This occurs when there is a sudden increase in BP. So you are probably seeing a white spot. Clear? So that is called a This is called a soft exudate. MCQ is soft exudate is a nerve fiber layer infarct. It is a nerve fiber layer infarct. That is MCQ. You are seeing that the disc margins are not well defined. So this probably may be a grade 4 hypertensive retinopathy. You also see hard exudates which are deposited like a star around the macula. Can you see? So that is again see, that is the one the hard exudates are deposited like a star around the macula. So macular star can be produced by hypertension. You understood? So a macular star is all around. In this picture also it is not fully all around, but only one half of it is involved. For example, if this is only one half, then it is called a macular fan, which is a feature of optic neuritis. So you are seeing this, you are seeing this around the entire macula, then it is like a star around the macula, then it is that is called a macular star, which is a feature of hypertensive, which can be there in hypertensive retinopathy. It can also be there in optic neuritis, but usually only one half, that is called, it's called a macular fan. So these things have not been asked, I just told you, but the fact that has been asked as MCQ is Fortin-Muhl sport is what? It's a nerve fiber layer infarct of the retina. Okay? The other fact which is asked as MCQ is hypertension can produce bilateral disc edema without any other finding of hypertensive retinopathy because of a sudden shoot in blood. So these are the other facts which is asked as MCQ from this area. Many times asked for our Kerala state entrance exam. This question. That's a quite simple question. Many times asked for our state entrance exam. Hypertensive retinopathy classification is Keith Wagner Barker, Early House classification, McCollum's classification, Rees Ellis Worth classification. What is the answer? Keith Wagner Barker classification. Any doubt? No doubt. Keith Wagner Barker classification is the classification for hypertensive retinopathy. Mind you, each of these choices has been asked as MCQ in various entrance exams. So what is Rees Ellis Worth classification? You must be probably knowing. What is that? Yes, it is the prognostic classification of retinoblastoma. Rees Ellis Worth is the prognostic classification of retinoblastoma. McCollum's classification, also a very commonly asked question, is a classification of, very commonly, many times asked for our entrance exam, state entrance exam. It's a classification of what? You just talk something. Somebody has told trachoma. Any other answer? See, I will not proceed without an interaction. I have traveled all the way from Madurai to come only because of my interest in teaching. Otherwise, I will not have come. Huh? You talk something, otherwise there is no point. What is McCollum's classification? Huh? So let us stop here. McCollum's is for? Yes, it is for trachoma. See, I told you, you have. This particular McCollum's classification, this question from, if you take from 2000 onward, the same question has been asked 4 times in state entrance exam. But you are not answering anything. It is a classification for trachoma. It's a classification for trachoma. House classification, any idea? Huh? You can just guess where the classification come and then answer it, it will be right. Huh? Yes, diabetes. There is classification for diabetes retinopathy, diabetic retinopathy. So, this particular question, you know, all these choices has been asked in MCQs. Not a feature of hypertensive retinopathy. Salicine, gun sign, bonnet sign, L-Schnick spots. So this is too much cooperation. And that looks very beautiful. L-Schnick spot is what? Huh? Yeah, it's a nice after cataract. See, things which are written very beautiful, no, they may be deceptive. That is not the answer. You understood? That is how you go wrong. That is how you will come back after an exam, you will, this question is surely I am right. But you know you are surely wrong in this question. So you are either non-cooperative or over-cooperative. Both are dangerous. You understand? Okay. If you read small textbooks in ophthalmology, you will definitely go wrong in this question. For example, there is a book called Qurana, which is practice used by many of our students. If you read that and answer this, you will go wrong. So I will solve your primary problem. That is your relation to L-Schnick. You know L-Schnick pearls or is an after cataract. That is, you
remove the cataract, put in an intraocular lens, again the posterior capsule gets opacified. You will appear like, there appears like, a rounded bubble-like things on the posterior capsule, which will opacify the posterior capsule and make the patient vision blurred. And that is L-Schnick pearls. Clear? But L-Schnick spot or the sea-grid spot is a choroidal infarct in hypertensive retinopathy. They are also white spots. It's a choroidal infarct in hypertensive retinopathy. Clear? Okay? So I will give you innumerable examples where you go wrong by over enthusiasm as we proceed.
Okay? So, L-Schnick's pearls is an after cataract, but L-Schnick spot is a choroidal infarct, which is again a white spot in hypertensive retinopathy. What is Salus sign? Again a many times asked question. Salus sign is, in hypertension, there are hypertensive changes in the vessel wall. Clear? As you know, fibrinoid necrosis, so many problems. So what will happen? All the vessels will get thickened. In the artery, you can see in the retina, you can see the artery and the vein directly. So you know where the artery crosses the vein. Because of these hypertensive changes, the artery will compress the vein. Okay? To escape from that compression, the vein will go little down and make a C-shaped loop. And that is called sun sign. You understood? Okay, that is Salus sign. It is a deflection of the vein away from the artery in the arteriovenous crossing areas or arteriovenous crossing junction. But I told you the vein will try to escape from the artery by moving away from the artery. That is Salus sign. How much ever the vein moves also, still the artery will compress the vein. Compress the vein and will produce, you will appear like interrupted blood columns in the vein. You understood? Because of the compression by the artery. And that is called the gun sign. You just listen to me. Many people have not understood. They are looking at others. Papers. See, I told you where the artery crosses the vein has to escape from that compression. So the vein goes away from the artery, and that is called Salus sign. How much ever the vein goes off, the artery will still compress it. And when you look at that junction, you see the blood column is interrupted on either side of the artery in the vein. And the vein will appear like tapered. That is a tapered end of a cricket stump. You must have seen. You must have seen the tapered ends of a cricket stump. The vein will appear like the tapered ends of a cricket stump on either side of the artery. And it is aiming or gunning something. And that is called gun sign. Okay? So both these have been asked as MCQ. See, these are not the facts. I just told you to remember the things. The vein moving away, it will look like tapered ends of a stump. All these are never been fact. I just told you to remember these things. Now you write down the other MCQ. Bonnet sign is the pre-thrombotic sign of a venous occlusion. The vein will appear tortuous and dilated just before a frank occlusion of the vein. That is called bonnet sign. And if you read Purana, it is given as a sign in hypertension, it is wrong. And if you answer, by reading Purana, then you will go wrong. So it is called a I just told you like this because you have to remember, it's a prothrombotic sign of bonnet. That means it is a sign of venous occlusion. It is not connected to hypertensive retinopathy. It is a sign of venous occlusion. Okay? So that's it. Which is not true regarding malignant hypertension. You just think I will get some sunny and come. Just some water and come. You just think. కొంచెం వెళ్ళాం So there lies somebody's answer, somebody's question. This is how questions comes. I told you, from same areas question come. I told you, I was asking you somebody about a question on diastolic BP. You know what is the answer? A, C and D. I got A, C and D. I am happy. One more. I will be fully happy. Why nobody wants to do, take B, Huh? But like I have discussed 3 questions, I am very happy that you have learned one point, that is disc edema is a feature of malignant but accelerated hypertension. At least that much you have learned. I am very happy. Then, when the question setter probably must have thought that when the diastolic BP goes above 140 millimeters of Hg, disc edema develops rapidly. You understood? When the diastolic BP goes above 140 millimeters of Hg, edema develops rapidly. That is sometimes called as accelerated bar malignant hypertension. Because various textbooks will give a value from 110 above, but majority of the textbooks gives a value of 140 millimeters of Hg as a diastolic BP, call it as malignant bar accelerated hypertension. So can hypertension produce vision loss? Sudden vision loss? How does it produce? Sudden vision loss? Where? It can produce small hemorrhages, it will not produce vision loss. It can produce sudden vision loss, unilateral, bilateral, sudden, total vision loss, especially in malignant hypertension. Blood, it's an ischemia, no, it's an ischemia. Hypertension is a state of, why hypertension will develop heart attack? It is a state of ischemia. So their blood supply to the optic nerve may be cut off, and infarction to the optic nerve can occur. So sudden vision loss is due to infarction of the optic nerve. Sudden vision loss is due to an infarction of the optic nerve. If that statement is correct, what about the last statement? I told you hypertension is a state of ischemia. Hypertension, the BP is very high. BP when you record maybe 220 by 120, 220 by 140, what will you do? What will you do? You must have been facing this in casualty or any OPD. You will give all antihypertensives through all routes to bring down the BP? No, you should not do like that. You should bring down the BP, but not very fast. I told you already it's an ischemic state of ischemia. Now when you bring down the blood pressure, what will happen? Ischemia will be further aggravated and cause infarction of the neuronal tissues, brain or the retina or the optic nerve or anything. So when the BP is very high, overzealous reduction of BP is not advised. You understood? It will cause infarction of the neuronal tissues, not other structures. It's an infarction of the neuronal structures. So that is why you should not bring down BP very rapidly. You should definitely bring it down, but not from 220 to 120. In 1 day or so, not advised. The answer to this question is D. This again is an Ames question. Fundus diabeticus is a full-blown diabetic retinopathy. It's a bilateral vitreous hemorrhage, mild proliferative diabetic retinopathy. It's only a venous dilatation. Answer is mild disease. Any other answer? Only venous dilatation. Huh? When somebody calls with some name, it should be what is them to believe it is a full-blown disease. Correct? Or it may be the beginning of that disease. When you call by some name to a particular disease, it can be either a full-blown disease or it can be the early signs of the disease. Where will you opt now? Any disease is like that only. Where will you opt? Huh? Then I have brought down your choices to 2. Mild. So you are divided opinion. Half says it's a mild diabetic retinopathy, half says it's a full-blown diabetic retinopathy, but both are wrong. In all diabetic patients, there is a peculiar thing. If you see in any diabetes, their veins will be slightly dilated. It's not visible in any part of the body. If you look at retina, you can see the veins are dilated in diabetes. That is called fundus diabeticus. Many times repeated question. Thus diabeticus is only a venous dilatation in diabetes. Clear? So we have gone around hypertension. We have looked into almost all the questions which has been asked from hypertensive retinopathy in the last few years. Almost all the questions which was asked from hypertensive retinopathy has been covered in these last 5-6 questions. Then now about diabetes, the other major disease. Question setter will definitely get questions. Questions should come hypertension, questions should come from diabetes, questions should come from retinoblastoma, questions should come from retinitis pigmentosa, questions should come from retinopathy of prematurity, questions should come from strabismus. These are the difficult areas, and so that is why if you see Ames question, they ask from retina, they will ask questions from retinopathy, fluorescent angiogram findings, they ask questions from strabismus, because these are the areas which is grey for the for the student. So that is why they ask this, because all others they are mastered, so they are going to more and more grey areas. So, but we will try to analyze all these areas, which is not true regarding diabetes. Mind you, these questions are slightly difficult. The only way you can learn is only from these classes, not by reading, because for you to read and understand it will take a lot of time. So which is not true regarding diabetes. The main risk factor is the duration of diabetes. Strict control of hyperglycemia delays the onset of diabetic retinopathy. Diabetic retinopathy patients are likely to have nephropathy, and comorbidities like hypertension, dyslipidemia have no bearing on the onset of diabetic retinopathy. Yes. I will tell you, this is a very badly constructed question. Anybody can answer this question. Clear? So, but the single most important risk factor for diabetic retinopathy is the duration of diabetes. So let us move away a little bit and go into your understanding about diabetes. I just want you all must be treating diabetes. You all must be identifying treating diabetes. Correct? Yes. Because 20% of the world's diabetic population lives in India. So it is going to get doubled in 2020. So you should know how to identify, treat diabetes. Let me ask you a very simple question. Can you just tell what is diabetes? I don't want to have it is a metabolic disorder like that. I just want to know at what blood sugar level you are identifying and treating this disease. Okay, very good. Somebody is telling that the blood sugar level up. So he has told me all FBS, RBS, HbA1c, all this. That is absolutely right. But when the American Diabetic Association coined the term diabetes, it was based on this particular value. Can you just tell? It was based on the blood sugar value. They just told when the blood sugar, they just told like this, blood sugar value of 126 or more. That is an FBS value of 126 or more. Why they exactly told 126 if they have told 125 or 150 or 100? See, if you don't answer this question, it's shame for us. I'm not telling shame for us, including me. We have the highest number of diabetic patients in the world. We are identifying treating diabetes. We know what is the definition of diabetes, but why? Yes, sir, you are right. When he is telling, it is that particular blood sugar level when the diabetes will produce complications. Why the American diabetes? What is studied to make a definition of diabetes? Anybody knows it? Otherwise I will tell, because I don't want to prolong this. American Diabetes Association has studied patients with blood sugar level of more than 120 and 125, 126. They studied many patients for over a period of long time. And they just looked at the development of diabetic retinopathy. So it is that blood sugar level above which diabetic retinopathy develops. So that was the basis for the coining of the term, coining of the blood sugar value for defining diabetes. You understood? It's unrelated to MCQ. I just told some people are taking it down. I just wanted to know whether you know what is diabetes, because we are treating diabetes. It is that blood sugar level above which diabetic retinopathy never develops. That is how they identified, that is how they came to that particular value of 126. Again, a slightly difficult question that is asked for the PG entrance exam, which is not true regarding diabetes. Decreased reading capacity, seeing floaters, sudden altitudinal field effect, sudden progression of nuclear cataract. This is slightly confusing question. Slightly difficult also. But the third choice there, no, it has been asked us many times, many ways in MCQ, in entrance exams. What is altitudinal field effect? Yeah, somebody has already told. The answer is the disease which produces altitudinal field effect. That means we see lower half may not be visible, upper half fully visible, or the upper half is visible or lower half is not visible. What is that disease? Huh? Yes, it is anterior ischemic optic neuropathy, or AION. It is the disease which produces multitudinal field defects. Again, many times asked question. So, it is an ischemia to the optic nerve. That is called an anterior ischemic optic neuropathy. The most common disease producing anterior ischemic optic neuropathy is either hypertension or diabetes, because they are the common disease. Okay? So hypertension or diabetes can produce anterior ischemic optic neuropathy. The other common disease producing anterior ischemic optic neuropathy is what? Middle-aged lady. I will give you the clinical history of this patient so you can make the diagnosis. A middle-aged lady who is complaining of headache, polymyalgia rheumatica, and headache on combing. That's a typical scalp tenderness or headache on combing the hair. Middle-aged lady complaining of scalp or pain on combing the hair, and polymyalgia rheumatica, multiple joint pain, giving sudden history of, giving history of sudden vision loss. The most likely diagnosis in this case is giant cell arthritis. This was exactly the CMC question which was asked. A middle-aged lady complaining of pain while combing the hair with polymyalgia rheumatica complains of sudden vision loss. The likely diagnosis in this, the clinical diagnosis in this patient is giant cell arthritis producing an anterior ischemic optic neuropathy. You know, giant cell arthritis is a very, very favorite question area for pathology, for medicine, from ophthalmology. Everywhere they ask questions from giant cell arthritis. I told you the features. The middle-aged lady, she is having scalp tenderness, she is having polymyalgia rheumatica, her ESR will be elevated. Her ESR will be elevated, but 40% of the cases will have a normal ESR. But the C-reactive protein is almost always elevated. They complain of sudden vision loss due to anterior ischemic optic neuropathy. So when a patient with a sudden vision loss with this history comes, what is the immediate thing that will do? That was the subsequent year question on. I took the question history with a patient with a scalp tenderness, polymyalgia rheumatica. What is the diagnosis? That is 1 year. The very subsequent year, CMC has asked a patient with this history with a vision loss, what is the immediate step that you will take? That exactly signifies the fact that the questions come repeatedly from the same areas. What is the immediate step that you will take? Yes, you should start steroids. Immediately you should start steroids. You should start IV methylprednisolone. Why? What if you don't do steroid? If you don't start steroids, what will happen? That is permanent vision loss because the other eyes also will go. So the other eye will be involved in 2 months' time. If you don't start steroids, the other eye will be lost in 2 months, leading to total blindness. After that, what will you do? The clinical history is very typical. You have started when when you took C-reactive protein, it's elevated, ESR, you have started patient on steroids. what is the next thing that will you do? Huh? You take a biopsy. You take a biopsy from the superficial temporal artery. Artery will not be pulsating. You take a biopsy from it. How will you identify superficial temporal artery? Just in front of the tragus. So the artery will not be pulsating. You take a biopsy within 2 weeks after giving steroids. Within 2 weeks after giving steroids. Because the biopsy will be negative after 2 weeks. So it is a factor of 2 in giant cell arteritis. The second eye, you have to give steroid, whether this if second eye will be involved in 2 months, you have to take a biopsy within 2 weeks, and you should take at least 2 centimeters of the artery. Because of the skip lesions in giant cell arteritis. So it's a factor of 2. Right, it's 2 months, 2 weeks, and 2 centimeters. You understood? Because if you take biopsy from a small area, it may not be positive. Because it's skip lesions in giant cell arteries. So that's about giant cell arteritis. The histopathological features of this disease are what? An intimal thickening, rupture of the internal elastic lamina, and a fibrinoid necrosis of the media and adventitia. All these facts have been asked as MCQs in various entrance exams about giant cell arteritis. So I will tell something which is not asked, but you just take down. It can produce 4 problems, giant cell arteritis. Giant cell arteritis may produce, as we have already told, anterior ischemic optic neuropathy. Second, it can produce central lateral artery occlusion. It can produce transient obscurations of vision, that is called amaurosis fugax. And it can produce cranial nerve palsies because of the involvement of the vasa nervorum. Okay? So giant cell arteritis can produce anterior ischemic optic neuropathy, it can produce central lateral artery occlusion, it can produce amaurosis fugax, and it can produce cranial nerve palsies because of the involvement of the vasa nervorum. So cranial nerve palsies in the eye may produce diplopia for the patient. Okay? So patient in your history they may give you diplopia also. So cranial palsies in the eye, they may produce diplopia to the patient. So any diabetes, long-term diabetes patient who complains of reading difficulty, in spite of, I met the doctor, he gave me a glass, still I cannot read. And then diabetic patient is complaining of that. Single possibility of diabetic maculopathy, diabetic retinopathy has already come. Okay? So reading difficulty may be due to diabetic maculopathy. Patient who is having long-standing diabetes complains. So yesterday morning I am seeing some black spots moving in front of my eye. What it can be? Yes, it can be floaters due to vitreous hemorrhage. Cause the diabetes. So, in diabetes, when the blood sugar goes up, glucose enters into the lens and the transparency of the lens is lost. So, you will develop a, yes, gone there. The lens will lose its transparency. You know, the lens is thickest, lens capsule is thinnest where all the toxins will enter into the lens from the posterior surface of the lens. Center of the posterior surface. Means center of the posterior capsule of the lens is the thinnest area of the lens. Thinnest lens capsule. Center of the posterior capsule. So all the toxins will enter through that area. And producing opacification in the posterior surface of the lens, posterior subcapsular area. That is why the complicated cataracts are posterior subcapsular. Here so the glucose enters into the lens and produces posterior subcapsular cataract. So it is actually producing what type of cataract? That is a cortical cataract, correct? Not a nuclear cataract. So that is the answer for this. There is some controversy in this question. I am not going into this, but this is a fact which I have told you. So it produces sudden hyperglycemia, produces cortical cataract. Answer is? C. Yes, nuclear, as all of you know, nuclear cataracts produce myopia. I told you, a diabetes produces posterior subcapsular cataract, so it should produce opposite of the nuclear cataract. So it should produce hypermetropy. So myopia, that is the answer. So, but in the question setter has a tendency to ask something with name. So snowflake cataract is diabetic cataract. Snowflake cataract is diabetic cataract. So all the cataracts with the name has been asked sometime or the other time. Cataract is trauma. Rosette cataract is trauma. Snowflake is diabetes. Then what other name? Sunflower cataract is in or chalcosis. Wilson's disease, chalcosis. Any other one? Oil droplet cataract in galactosemia. Then Christmas tree cataract in myotonic dystrophy. Christmas tree cataract. Christmas tree cataract in myotone. No? He is doing something there. Okay. Audible? He is constantly working out something there. So, Christmas tree cataract in myotonic dystrophy. Any other cataract by name? Huh? Any other cataract which has been asked as MCQ? It's a favorite question area. Huh? Correct. What is that? Propeller cataract. P-R-O-P-L-L-E-R. Propeller cataract. In what disease? It's a favorite area for the question setter. Huh? What disease? Fabry's disease. Fabry's disease. Fabry's disease. F-A-B-R-Y-S. The usual question is the deficiency in Fabry's disease is, yes, correct? Correct? Tell. It is alpha glucosidase deficiency. Alpha glucosidase. And I am not going into the details of Fabry's disease. It is a very favorite area. It has got so many other findings. I think you will go through this. Endocrine problems, skeletal problems, all of them. You should go. This is another area where you have to read Fabry's disease. Okay? So that's it. Of the male cataract. Oxidative detachment is produced by all except anemia, pregnancy-induced hypertension, uremia, leukemia. Huh? What is it? Any idea? No, oxidative detachment is collection of fluid behind the retina. What all situations there can be collection of fluid? AS, uremia, huh? Anemia, how it produces retention of fluid? It produces a high output cardiac failure because there is not much oxygen there in the blood, so it will pump out more. So that will produce high output cardiac failure, retention of fluid, and that cause oxidative detachment. This is a common repeat question. Huh? For our entrance exam, this is a repeat state entrance exam. A repeat question. You now just take down this particular fact because you will not be able to answer this question. You just take down. Coats disease is Coats disease. C-O-A-T-S. Coats disease is a typically unilateral disease. It's a typically unilateral disease characterized by if you are not hearing, you can come down here, you can adjust in this place. You can bring a chair and sit here, no? If you are not hearing it. you can take this chair. Here there are two chairs. Okay. So it's a typically unilateral disease in young males. I mean, in males, typically unilateral disease in males around the age of puberty, characterized by retinal angiomas. Characterized by retinal angiomas. These angiomas will lead on to subretinal exudation. Which will push the retina forward and so will have a white reflex. So the child will have a white reflex or the child will have a strabismus. So simple, it is a condition where there is angiomas in the retina. These angiomas will leak, producing exudation behind the retina. So what will happen? Retina will come forward and it will come in the pupillary area, so that when you look at this patient, you will have white reflex in the pupil. Clear? So that eye was not used for a long time, so that eye goes for a deviation. So the child may have a strabismus. So this has also been asked as an Ames question. Quartz disease. Quartz disease typically of unilateral disease. Now you know the answer. Answer is? The most appropriate method of follow-up of the other eye for a child who has an enucleated eye with retinoblastoma. Very, very favorite area for the question such as retinoblastoma. You should know everything about retinoblastoma. Yearly fundus examination with 90D lens till the age of 10 years, indirect ophthalmoscopy yearly throughout lifetime, indirect ophthalmoscopy yearly till the age of 10 years. C, yes, answer is C. Indirect ophthalmoscopy yearly throughout lifetime because of the risk of an adult retinoblastoma. Okay? You can just take down the sentences of Parcel which is asked as MCQ. Indirect ophthalmoscopy yearly throughout lifetime. You can just take down it. This is the sentences of Parson. Indirect ophthalmoscopy yearly throughout lifetime in a fully dilated people with scleral indentation. Scleral indentation. You press the sclera and see. You press the sclera and see. So it is indirect ophthalmoscopy yearly throughout lifetime in a fully dilated people with scleral indentation because of the adult, because of the risk of an adult retinoblastoma. Scleral indentation, why? Because even if something is not visible, while you indent and bring it into your view, you understood. You understood. You press the sclera, bring it into the pupillary area so that you will be able. So this is because of an adult retinoblastoma. So we will discuss everything about retinoblastoma in another 5-10 minutes. All these questions which has been asked. The trilateral retinoblastoma is trilateral retinoblastoma. Yes, it's a bilateral retinoblastoma with pinealoblastoma. It's a bilateral retinoblastoma with pinealoblastoma. Pineal gland tumor. Pineal gland tumor. And pinealoblastoma. Only 5% of the retinoblastomas are hereditary retinoblastoma. The cell of origin of retinoblastoma is the cell of origin of retinoblastoma is the cell of origin of retinoblastoma is you tell something, some cell you tell. Tell. Then a simple question. What is the cell of origin of retinoblastoma? Ganglion cell. Any other cell? There are other cells I will tell. Muller cell. Any other cell you want to know? Amacrine cell. Any other cell in the retina you know? Horizontal cell. Any other cell in the retina you know? Pigmented epithelial cell. Any other cell you know? Rods and cones. That is the cell of origin of retinoblastoma. You are very particular. You will tell the answer only last. But time will not wait for you. Retinoblastoma originate. It is a tumor of photoreceptors. It's a tumor of photoreceptors. The diagnostic histopathology finding in retinoblastoma is somebody told rosette, somebody told Homer right, somebody told pseudo rosette, somebody told Homer right rosette, somebody told flexner intestinal rosette. These four were the choices in that question, original question. So the diagnostic histological finding is flexner intestinal rosettes. Flexner intestinal rosettes. Flexner, Flexner, WIN, intestinal rosettes. But Homer-right rosettes are also seen in retinoblastoma. But it is specific for neuroblastoma. Both of these tumors have both the rosettes. Both these tumors have both these rosettes, but each is specific for each. Clear? So, flexner intestinal rosettes are specific for retinoblastoma, while Homer-right rosettes are specific for neuroblastoma. Pseudo-rosette is tumor cells arranged around a blood vessel. That's also seen in retinoblastoma. Pseudo-rosettes are tumor cells arranged around a blood vessel. That is also seen in retinoblastoma. There is another histological finding called fluoret. F-L-U-R-E-T-T-E. Fluoret. Fluoret is the presence of, the MCQ is the presence of fluoret means the tumor is very well differentiated. Presence of fluoret means the tumor is very well differentiated. Fluoret is nothing but the tumor cells arranged around a space, and the middle space will have neurofibrillary tangles. The tumor cells arranged around a space, and in the middle of this there will be neurofibrillary tangles. The presence of fluoret means the tumor is very well differentiated. Very well differentiated means it is amenable to, is very well amenable to, answer is, what is the treatment modality in well differentiated tumors? Take mudiyadu. Very well differentiated, whenever tumor is amenable to, very well differentiated means that the tumor is very amenable to radiotherapy. The tumor is very amenable to radiotherapy. That means fluoret means the tumor is amenable to radiotherapy. Okay. Now we will go into the treatment of retinoblastoma, which was exactly the question that was asked in the last All India entrance exam. Last year All India entrance exam. The treatment goes like this: small tumors, that is unilateral tumors, small tumors less than half of the globe, that is not involving the optic disc or the macula. Treatment is radiotherapy. Large tumors, the words are all important. Large tumors means tumors more than half of the globe. That means involving the disc and the macula. That means there is no salvageable vision. The treatment is enucleation. Bilateral tumors, both less than half. That means both small tumor. That means both not involving the disc and the macula. Clear? The treatment is again bilateral radiotherapy. Bilateral tumors, one larger than the other. Treatment is enucleation of the more advanced dye and radiotherapy the less advanced dye. Clear? So this exactly was the question in 2011 Olympia entrance exam. These were the these varying combinations of this. So a small tumor, the word means small tumor means less than half of the globe, not involving the disc and the macula. The treatment is radiotherapy. Large tumor means tumor more than half, that means involving the disc and the macula. The treatment is enucleation. Bilateral tumors, both small tumors, the treatment is bilateral radiotherapy, and both eyes, one eye more advanced and the other eye more advanced eye to be enucleated, and radiotherapy to be less advanced eye. This exactly was the treatment. And the other MCQ that has been asked on the treatment are SALT, salt. SALT is a treatment modality in retinoblastoma. CGA entrance exam question of 2010. SALT is a treatment modality in retinoblastoma. It is there in your Quran also, not in many books. No big books you have to read to answer this question. SALT. That is 2010 CGA question. Salt. Then the next MCQ that is asked is the vitamin that is used in the treatment of retinoblastoma is again a PGA question. Vitamin D. The drug with anti-helminthic properties used in the treatment of retinoblastoma is yes, levamisole. So both levamisole and vitamin D, both are called radiosensitizers. Radiosensitizers. The tumor most commonly spreads to retinoblastoma, most commonly spreads to you answer something. There are so many structures in the body. The tumor most commonly spreads to answer Nothing you can tell, sir. Huh? Where? Talk loudly. Huh? I'm not hearing anything. It spreads to brain, it can spread to liver, bones, many structures, no? Any tumor will spread like this. So I just want to know where, whether you know where the retinoblastoma spread. Optic nerve, somebody had told. It's not called as, it's not, usually will not tell a tumor spread to optic nerve like that. You will tell whether it is going to liver, it's got to lungs, or to bone, or to brain. So you take this MCQ, it most commonly spreads to CNS and most often metastasizes to flat bones and vertebra. Okay? Both were MCQs. Mind you, there is a subtle difference only in these questions. It most commonly spreads to the CNS along the optic nerve, and it most commonly metastasizes to the flat bones and the vertebra. Okay? Both are different. Both has been asked. Both has been asked. Both are different. And the investigation of choice in the spread of retinoblastoma is what? Huh? It spreads along the optic nerve. So the investigation is neuronal tissues, MRI. So the investigation of choice in the spread of retinoblastoma is MRI, but the investigation of choice in the metastasis of retinoblastoma is CT scan. Okay? And the enzyme assays that are done, in retinoblastoma are
He's taking away all, mic away. So you're audible now? I'm audible there, back? Huh? Okay. He's taking away that, okay. I think people have come here, that is why, yes. Where were we? The enzyme assays that are done in retinoblastoma is an institute itself. PGI, phosphoglucose isomerase, LDH, and non-specific enolase. Okay? So the three enzyme assays that are done in retinoblastoma. Now, second tumors in retinoblastoma. I told you, too much enthusiasm will bring you in problem. Second tumors are tumors which are seen away from the site of radiotherapy in retinoblastoma. And the most common second tumor is osteogenic sarcoma. Because the locus for the retinoblastoma and osteogenic sarcoma lies in the same chromosome, that is 13q, which is the long arm. See, such confusion should not come. The q ends with an extension. It doesn't stop there, it goes and stops. So it's the long arm of the protein. So it is 13q. The average age of diagnosis of retinoblastoma is again 3 years. diagnosis of osteogenic sarcoma is again 3, that is 13. So it is 13Q, 3 and 13. Okay? So, but any tumor including skin tumors can be the second tumor. Any tumor including malignant melanoma of the skin can be second tumor. But the most common is osteogenic sarcoma. And the other question that has been asked from retinoblastoma is, the prognostic classification in retinoblastoma is called Reisel classification. I think I have gone around almost all the, one more question that is not has been, the benign variant of retinoblastoma is, the benign variant of retinoblastoma is retinocytoma. Retinocytoma, which is an astrocytoma. Astrocytoma, it is considered as a benign variant of retinoblastoma. It's an astrocytoma, and it is commonly seen in this condition, retinoastrocytoma. A disease called Bone-Willis disease. What is the disease? Tuberous sclerosis. And the tumor is called mulberry tumor of the retina. It's called the mulberry tumor of the retina. Okay, so I think I have gone around all the MCQs that has been asked on retinoblastoma in the last 4 or 5 years. Now you see, all are true about, true regarding, this is state entrance, Kerala state entrance question, all are true regarding nucleation retinoblastoma except so it's a malignant tumor, so you naturally have to have minimum malformation. It's a malignant tumor, so naturally you will expect more bleeding. You expect more bleeding. Longest possible optic nerve should be cut, correct or not? Yes, because you don't know how far the tumor has extended, so you go around presuming that you are going around behind the extension of the tumor. So the important feature is when the tumor spreads along the optic nerve, the tumor, the optic nerve will get thickened. It will get thickened. Some areas it will be thickened, some areas it will not be thickened, again some areas it will be thickened. That is why you have to cut longest possible optic nerve, because there may be skip lesions. You understood? When the tumor spreads along the optic nerve, some areas of the optic nerve will be thickened, other areas may be normal, other areas again thickened. And this thickening of the optic nerve will cause erosion of the optic foramen. So indirect evidence for the spread of the tumor is a widening of the optic foramen in CT or an X-ray. You understood? So it is a bleeding of the optic nerve. You just take down some bleeding of the optic nerve and a widening of the optic foramen. These are the features of these are the features of the a bleeding of the optic nerve and a widening of the optic foramen are the features of the retinoblastoma. Again, another area from where questions come is retinitis pigmentosa. We will discuss on all rather than going into these questions. Retinitis pigmentosa, the most reliable sign of retinitis pigmentosa is, the most reliable sign of retinitis, you must have all read or you must have drawn, this question must have been asked, draw the picture of retinitis pigmentosa in MBBS. Huh? The most reliable sign of retinitis pigmentosa is bony specule pigmentation. Because you all know whenever something happens, some question RP, fundus picture of retinitis pigmentosa asked, what do you know is to mark with a lead pencil, black back. This is a beautiful appearance. but sadly again deceptive. It is not the answer. The most reliable sign of retinitis pigmentosa is the arterial attenuation. Arterial blood vessels will become very, very small. That is the most reliable sign of retinitis pigmentosa. And the least reliable sign is also you are one. All these beautiful things are always deceptive. Lady or whether beautiful things in life, they are deceptive. So again, bony spicule does not come. Waxy pallor of the disc is the least reliable sign. So the most reliable sign is an arterial attenuation, and the least reliable sign is a waxy pallor of the disc. Both were repeat MCQs. Most reliable is arterial attenuation, least reliable sign is waxy pallor of the disc. So your bony spicule does not come anywhere. Now you take down what I say, because this particular fact which I am telling you is asked as many times, repeat combination. The associations of retinitis pigmentosa are from anterior to posterior, are a floppy eyelid, F-L-O-P-P-Y, a floppy eyelid, just behind that the corneal curvature is more, so that is keratoconus. Just behind that, the pressure inside the eye may be high, that is primary open angle glaucoma, or POAG, primary open angle glaucoma. Behind that in the lens there may be posterior subcapsular cataract. Behind that there is something called PVD, posterior vitreous detachment. Behind that, in the optic nerve, there is drusen of the optic nerve, DRUSEN, drusen of the optic nerve, and Coats-like disease, COATS, Coats-like disease. Coats-like disease. So you are seeing this optic disc as something which is elevated, correct? You are not seeing the optic cup, the margins are very irregular, you are not seeing the optic cup. But these particular, these patients know when it is bilateral, somebody will be tempted to believe that it is papilledema. Patient may give a history of headache, vomiting, so they will be tempted to believe that it is papilledema. When they will order for a CT scan, but CT will come normal. So what is the diagnosis then? Correct. It's called, when you have headache, papilledema, signs of raised ICT. On examination there is papilledema, but on CT scan there is no space occupying lesion. The diagnosis is pseudotumor cerebri. So again the profile of the patient is middle-aged, obese. So you may, when you see such things, ultrasound will show. This is this last picture. This picture is in fact one of our sisters. Fundus ultrasound. This is an ultrasound from one of our sisters. She had bilateral recurrent headache and vomiting. On examination, she found to have bilateral disc edema, and CT was taken. It was seen as pseudotumor cerebri. Since there was nothing seen, it was diagnosed as pseudotumor cerebri, and she was advised ventriculoperitoneal shunt. And she was about to go for ventriculoperitoneal shunt. She came for an examination. Fundus examination, disc was appearing like this. On ultrasound, you see something on. This is an optic nerve shadow. On the center of the optic nerve, there is something which is calcified, looking like. This is called drusen of the optic nerve. This can be seen even without retinitis pigmentosa, and this will make the disc appear as pseudo-papilledema. That is MCQ. Pseudopapilledema is seen in drusen of the optic nerve. So I know this sister for the last 4 or 5 years. She has not undergone any ventricular peritoneation. She is on treatment now, and for migraine, she is aram se walking around. There's no problem. So this is a simple examination to tell you whether the patient has got whether true papilledema or whether the patient has got a pseudopapilledema. So the condition producing pseudopapilledema is drusen of the optic nerve. So I will repeat the associations retinitis pigmentosa are a floppy eyelid. You can just pull down the eyelid like this, it will stretch like a rubber sheet. That is a floppy eyelid, and behind that the patient may have keratoconus. Behind that there will be primary open angle glaucoma. Behind that on the lens there will be capsular cataract. Behind that there is a vitreous will be separated from the retina. There is posterior vitreous detachment. Behind that there is drusen of the optic nerve and a cords-like disease on the retina. So these are the associations which has been asked with varying combinations. And this question itself, I told you, is again not a very well framed question, because anybody can come in with two questions, two answers. What do you mean? Yes. The answer is what? No. You must be thinking because the cataract may be producing posterior subcapsular cataract may be producing hypermetropy. But the cornea is so much protruded now, that is keratoconus may be associated, so the patient will develop myopia. So the answer is hypermetropy. Again, so many times asked question. CHRPE is associated with premalignant conditionally colon. So it is associated with what premalignant condition? Yes, it is associated with congenital hypertrophy of the retinal pigment epithelium, that is CHRPE. So it is associated with the premalignant condition colon called familial adenomatosis coli or polyposis. Familial adenomatosis polyposis. The patient must have come for some routine ophthalmic examination. When you see a scar like this, this is called congenital hypertrophy of the retinal pigment epithelium. The patient should undergo colonoscopy to rule out familial adenomatosis coli, which is a premalignant condition. When this is associated with multiple osteomas, Gardner's syndrome. When this is associated with multiple osteomas, it is called Gardner's syndrome. Yes, now you have seen how congenital hypertrophy of the retinal pigment epithelium will look like. Now you can see multiple similar things on the retina. Larger ones here, the smaller ones towards the periphery. This is as if they say is called a Baer track sign. BEARTRACK, Baer track sign in retina is again associated with it's a multiple CHRP on retina. Baer track sign. It's as if some bear has walked through the retina. It's called a Baer track sign. Baer track sign is a feature of again congenital hypertrophy of the retinal pigment epithelium. Again multiple ones. Multiple CHRPs. Answer is maxillary. But the most striking feature is one is pitial, but that does not come in MCQs as an answer. Anywhere. The least reliable sign is vaccipallar, and the most reliable sign is viral attenuation. Salmon patch hemorrhages are a feature of sickle cell retinopathy, Lees disease, congenital syphilis, and leukemia. Answer is sickle cell. Any other answer? Any other answer? It's a very commonly asked question. Had the question been Salmon patch, what would have been the answer? Had the question been Salmon patch, the answer would have been both has been asked. Yes. Salmon patch is an interstitial keratitis in congenital syphilis. It is an interstitial keratitis in congenital syphilis. While Salmon patch hemorrhages are a feature of sickle cell retinopathy. Hemorrhage means it is in the retina. You understood? Simple Salmon patch means it is in the cornea. Salmon patch hemorrhages means it is a retinopathy. Salmon patch hemorrhages are a feature of sickle cell retinopathy. Sickle cell retinopathy is a favorite question area. Congenital syphilis, Salmon patch is a feature of, which is a feature of interstitial keratitis in congenital syphilis. What is that, by the way, what is Salmon? You all know. It's available in Calicut. What is only Icora is available? Huh? Where this is a freshwater or seawater fish? Huh? Huh? Seawater? Freshwater? Both. There are both freshwater and seawater salmons today. You must have seen, if you have seen Discovery Channel, you must have seen hyena coming and picking up from shallow waters a red-colored fish and catching its neck and peeling it in two pieces. The cover will just come out in two pieces. That is, salmon is a very costly fish. It must be available in big hotels here. A costly fish. You must have seen salmon, that I am sure. Not only Discovery Channel, you must have seen salmon. Definitely you must have seen, you must have seen movies. Huh? You must have seen olden English movies. If you see, the movie will start like a river flowing and you see some fish will be jumping up and up. No? The important feature of salmon is it jumps against the flow of water. This is an old English movies in that you will see the fish jumping against the flow of water. The highest concentration of salmon is seen in the Amazon, which is, of course, the river with the highest volume of water. So, Salmon patch is an interstitial keratitis, while Salmon patch hemorrhages are a feature of sickle cell retinopathy. I told you sickle cell retinopathy is a favorite question area. This type of hemorrhage is color with almost like a salmon patch hemorrhages. So this is a salmon patch hemorrhage. What is this? Suppose this was the previous picture. Later if you look at this, it will become a black scar, and that is called a dark sunburst. It's a scar. E-A-R-K, a dark sunburst, which is a scar at the region of the salmon patch hemorrhage. After the hemorrhage goes off, it will be like a scar. And that is again a feature of sickle cell retinopathy. And this particular thing is maximum time asked question. You have a stock and you have something which is like a, I don't know what you say in here in Trivandrum they say viscery. I don't know what it is. See? So because you will have a different thing from everything. So, something which is looking like a fan. What fan? What fan is the question? Something which is looking like a C-fan neovascularization. Most often asked MCQ in sickle cell retinopathy. C-fan neovascularization. S-E-A-F-A-N. C-fan neovascularization is a feature of sickle cell retinopathy. These are the three MCQs about the features of sickle cell retinopathy that has been asked. Salmon patch hemorrhages, dark sunburst, and C-fan neovascularization. Now what will happen? This will bleed. This will bleed into the vitreous. You understood? So in sickle cell retinopathy there can be vitreous hemorrhage. Now what will happen to the blood in the vitreous? It will get organized. What will happen now? It will pull out the retina. So that is called fractional retinal detachment. C for neovascularization, leading on to vitreous hemorrhage, leading on to tractional retinal detachment. That never been asked. I thought maybe they can ask this. Of course, Calicut has got some close association with the It's closely related to sickle cell disease. I mean, may not be sickle cell disease, but sickle cell trait. Correct? Yes. Yeah, it has got in Wayanad district of Kerala is having the highest concentration of sickle cell trait. And many of these places have got, and this place has got so much research centers, even from AIMS, even from Amrita Institute, all are having their own research places in Wayanad. So all of them regarding sickle cell disease, coma-shaped conjunctival vessels, or sometimes question comes as corkscrew-shaped conjunctival vessel. Cork, C-O-R-K-S-C-R-E-W, corkscrew-shaped conjunctival vessels. Hypochromic spots in the iris, hypochromic spots in the retina, all are true. Clinically mild disease produces the milder forms of the retinopathy. False, it is false. Actually, SC disease, that is the trait, and sickle cell thalassemia, these are milder varieties compared to the SS disease. Understood? SS disease is the most severe, systemically severe disease, but they don't produce much eye disease. But the milder variants like the sickle cell C, SC trait and sickle cell thalassemia produces the most severe forms of the disease, eye disease. You must be wondering why it is. SS disease, what will happen? There is almost no blood supply to the end organs. Almost no blood supply. It is like a dead area. But when there is sickle cell, a milder disease, what will happen? There is relative ischemia. Blood is coming, but it is not sufficient. The other time, SS disease, blood is not at all coming, it is useless. That means there is a stage of anoxia in one, and there is a stage of hypoxia in another. So whenever there is hypoxia, natural tendency of the body is to produce new blood vessels, as I have told you. That is C form. That will be producing traction retinal detachment. So clinically milder disease produces the most severe form of retinopathy. That much only you need to understand. Clinically milder disease like sickle cell C disease and sickle cell thalassemia produces the most severe form of retinopathy. I will leave some of these questions to go into the more important questions. But I would like to show you this picture. This appearance of yellow spot, this is actually leukemic deposits in the retina. And this is especially common with lymphatic form of the leukemia. And this is called leopard spots in the retina. But I will go to more important questions. Which is not true regarding single retinal artery occlusion. Answer is as you talk loudly so that you have to move fast. See, Hollenhaus plaque is a fibrinoplatelet emboli which cannot produce occlusion anywhere. It's a fibrinoplatelet emboli which cannot produce occlusion anywhere. It's such a small structure. Fibrinoplatelet emboli, it is Hollenhaus plaque. is polyarteritis nodosa? It is an arthritis. So it will definitely produce occlusion in any of the arteries, especially in the heart. It can produce occlusion in the vessel. Then it's an ophthalmic emergency. Yes, it is an emergency. So cardiac disorder is the commonest cause. That is the wrong answer. So what would have been the answer? What is it? This is stroke now. So what is the cause of stroke in elderly? Carotid atherosclerosis is the commonest cause of stroke in the body in an elderly patient. So in CRIO also, that is the cause. But in a young patient with CRIO, cardiac disorder is the commonest cause. But in an elderly patient, it's a stroke. So the cause is a carotid atherosclerosis. Okay? So that is the answer. I just wanted to show you these pictures. Answer is what? Yes, cherry red spot. So this is a central artery occlusion with some part is red still. This is because there is something called a cilioretinal artery here. It supplies this area. That is why this area looks red. You can see only one half is involved. This is a branch retinal artery. So I just show you these pictures because it may be asked if pictures are coming as MCQs. You can see entire area is yellow, retina is yellow, only this area is red. That is because of the cilioretinal artery. You can very well clear that only the upper half is involved, one half is only blocked. The branch retinal artery occlusion. Again, only one half is involved. That's again a branch retinal artery occlusion. So carotid artery disease is the commonest cause in elderly, while cardiac disorder is the commonest cause of CRIO in children. So, which is true regarding CRIO? Chance of neovascular glaucoma is more than that of CRVO. Is it correct or not? Why? Exactly the reason that I told you previously in sickle cell disease. In CR, central artery occlusion, it is total occlusion. There is death. But in CRVO, there is a state of ischemia. So new blood vessels will develop and so bleeding will develop. So you know the most common cause of neovascular glaucoma is diabetes. Diabetic retinopathy is the most common cause of neovascular glaucoma because it's a common disease, more common disease. The second commonest cause is what? Central retinal vein occlusion. So the neovascular glaucoma develops around 3 months after central retinal vein occlusion. So it is called 100th day or 90th day glaucoma. It's otherwise called thrombotic glaucoma. That is otherwise called so it's called neovascular glaucoma, congestive glaucoma. It's different from acute congestive glaucoma. So it is called neovascular glaucoma, congestive glaucoma, thrombotic glaucoma, 100th day glaucoma. That's all post CRVO. Neovascular glaucoma following post CRVO. The answer is, can CRV occur in young people? Yes, because the previous MCQ itself told the commonest cause in elderly is carotid disease and the commonest cause in children is cardiac disorder. So it can, CRV cannot occur in young people. That is wrong. It can occur. The chance of neovascular glaucoma is more than that of CRVO. That is false. The treatment of choice is IV heparin. That's false because in central vein artery occlusion, the blood is not coming into the artery. Why? Because the pressure inside the eye may be blocking it. The way to bring the circulation is you reduce the intraocular pressure, either by giving mannitol or by giving acetazolamide or by giving paracentesis. Let out some fluid inside the eye so the perfusion will start. So IV heparin does not have a role. So the important factor about single arterial occlusion is 5%, 20% of these people are going to die in the next 5 years. If somebody develops CRAO, 20% of these people are going to die in the next 5 years. So it is a significant mortality indicator. So that is the true statement in it. CRAO, 20% of the people will die in the next 5 years. What is what? Now it's tea break. You can come back fast. I can go to maximum question because I will be coming only 2 times after. Only one more time only after this. You come back very fast so that I can discuss most important questions. Let's start. See, I saw many of you are wearing glass specs. No, many of you have specs. At least, I mean, at least 40% of you have specs. Have you ever thought who has had the, who had the brain to discover spectacles? Had it not been there, would it have been our fate? Without specs, at least half of you will be partially blind at least. You know who has discovered these spectacles? book called History of Medicine. History of Medicine. It's a very, very interesting book. You will see, you will find out how many things were discovered. The only thing we know is about Alexander Fleming, how he discovered penicillin. Similarly, there are a lot of interesting stories behind many of the medical discoveries. You know, medicine has got so many Nobel Prizes, but all are for molecular biology. All are for molecular biology, either for insulin or for molecular biology things. But very few true discoveries in medicine has got Nobel Prize for that discovery. Only for molecular biology we have got medicine has got a Nobel Prize. But only some discovery of some instrument, something to examine. Only one instrument has got Nobel Prize winning discovery in medicine. What is that? Ophthalmoscope? No, not microscope. Not stethoscope. So that will bring in the another question. You have seen, I have seen, you must have seen, everybody must have seen, but you may not have recognized it is a Nobel Prize winning discovery, and that too is the only Nobel Prize winning discovery for an instrument in medicine. It is slit lamp. You must have walked around the front, behind, everything, but I never thought it was a Nobel Prize winning discovery. Actually, somebody was selling stethoscope. That brings us to the discovery of stethoscope by what is the patient whom he first examined? What is his original stethoscope? Not wooden. Hollow tube of what? Of paper. How many papers? No, one day one patient had come to Lanark. That time no stethoscope. He was hearing some sound, and so he how to examine this patient. And sadly he was a lady. So he was thinking, I cannot, she had come with a husband, so she cannot naturally, the other way, that time it was examined by keeping the ear over the patient's chest. Lady coming with husband, then so he thought it is not a wise idea. So he had to, he told the patient, you go back and come tomorrow. Like that he told. So he was thinking the whole night how to examine her chest. Then he has taken rolls and papers, 150 papers, made a barrel shaped tube, and that was the first stethoscope. And what is the first patient examined by what disease? In Boston. What patient? What patient? Any idea? Even now it's mainly used as a cardiac instrument, but it is originally devised to examine a pulmonary tuberculosis patient. The first patient was a pulmonary tuberculosis patient in Boston. Now there are so many other stethoscopes with sounds which will not, which will delete the other sounds, like only heart sounds. It will delete only heart sounds, delete heart sounds, pick up only lung sounds, and delete other sounds and the surroundings. So many other things are there which we are not going to inside. But we will directly go into the question. I will just show you this picture. What this appearance is. This is a venous occlusion. You can see dilated veins, fundus full of hemorrhages, and that is called the thunderstorm appearance in CRVO. MCQ. THUNDER. Thunderstorm appearance in CRVO. It's a fundus full of hemorrhages. So this patient will complain of marked decrease in vision. The vision will be less than 6/60. Vision will be less than 6/60. He will have a relative afferent pupillary defect, RAPD. So the patient has got a marked decrease in vision, a relative afferent pupillary defect and a thunderstorm appearance in retina. So there is a relative afferent pupillary defect means vision is already less. There is a conduction problem along the optic nerve. And the vision is also reduced because of the edema in the macula. Clear? The macula, the retina has got edema because of the blockage of the vein. But this appearance is called an ischemic central retinal vein occlusion. Ischemic central retinal vein occlusion is just got features of vision very less, relative afferent pupillary defect, fundus full of hemorrhages called thunderstorm appearance, and macular edema. This is a meaningless question. I just want to solve out that question. This is the other variant of this disease, that is a non-ischemic CRVO. Here you don't see much hemorrhages, the vision will be good, there will not be any relative afferent pupillary defect, there will not be any thunderstorm appearance. This is called a non-ischemic CRVO. So I told you there will not be any reduction there will not be any marked reduction in vision. Vision will be better than 6/60 always. Vision will be better than 6/60. There won't be any ROPD. There won't be any thunderstorm appearance. Here there is no ROPD. That means there is no conduction problem along the optic nerve. Here the vision is reduced because of macular edema. In ischemic CRVO there is both conduction problem along the optic nerve and also in the there is macular edema. Here there is only macular edema. So these are the two variants of the ischemic CRVO. Of the CRVO. One is ischemic variety where the vision is less than 6/60. There is relative afferent pupillary defect. Fundus examination shows a thunderstorm appearance. So there is an ROPD, there is macular edema. But the non-ischemic variety, vision will be better than 6/60. There is no ROPD because there is no conduction problem in the optic nerve. But the vision is reduced because of macular edema. You understood? There is no thunderstorm appearance. That was the MCQ. This was the 8th sentence exam question. Answer is B. Yes. A non-ischemic CRVO can get converted after some weeks, can get converted into ischemic CRVO. If you know this much fact, then you can answer this question. Otherwise, this looks a very, very tough question. So I told you, and now you just listen to me. In central retinal vein occlusion, I told you the patient may develop neovascular glaucoma. How does the doctor will know? When the patient will come for the examination, you see neovascularization of the iris. Clear? So whenever there is neovascularization of the iris, that is the indication for laser photocoagulation of the retina. You just listen to me. Whenever there is CRVO, what will happen? There is a state of ischemia to the retina. Now, whenever there is ischemia, what will be released? Oh, VEGF will be liberated. This will migrate towards the anterior segment along the vitreous, along the pupil into the anterior segment, because it has to be flowed out. It has to flow through the, through the trabecular meshwork and washed out. The retina, it was migrated along the aqueous humor, vitreous along the aqueous humor, then has to be washed out through the trabecular meshwork. So it will come and deposited over the iris. So there will be neovascularization. So whenever you see neovascularization of the iris after a CRVO, that means the process has started. What will you do? You have to stop the supply of VEGF. So what will you do? You convert that ischemic retina into a totally dead retina by giving laser and burn that retina. You understood? So that is MCQ. The indication for photocoagulation in CRVO is neovascularization. Listen to me. Now the patient has developed, patient is coming at the stage of glaucoma. This patient has not come at the stage of neovascularization of the iris. Now this neovascularization over the iris has gone, extended along the iris into the trabecular meshwork, covering that area. So the pressure inside the eye will go up. So the patient has come to a neovascular glaucoma. both these stages you have to give to ablate the retina to supply to reduce the supply of the stop the supply of the VEGF. Then only these vessels will regress. The VEGF is not only necessary for the initiation of the vessel, but also necessary for the maturation and proliferation of the vessel. So once you stop the supply of the VEGF from the retina, then this process will stop. So the indication for laser photocoagulation in CRVO is neovascularization of the iris and also the neovascular glaucoma. Clear? Yes. The indication for photocoagulation in CRVO is neovascularization of the iris or neovascular glaucoma. So this particular fact is sometimes asked as MCQ, the high risk characteristic for central retinal vein occlusion. High risk characteristic means the characteristic necessary for laser photocoagulation. High risk characteristic for CRVO means the indication, the characteristic which is necessary for laser photocoagulation. It has been asked like that only. High risk characteristic for CRVO means the characteristic which is necessary for photocoagulation of the retina, that is neovascularization of the iris or neovascular glaucoma. For diabetes also they have asked, in sentence, the entrance has asked, high risk characteristic for diabetic retinopathy. There is no other way but you have to learn it. I will just tell you, you have to take down. Neovascularization of the disc, that is the first high risk characteristic, of more than 1/3, around 1/4 to 1/3 of the disc area. If a neovascularization covering more than 1/3 to 1/4 of the area of the disc, then it is a high risk characteristic. Second, a less severe neovascularization of the disc with vitreous hemorrhage or retinal hemorrhage, with vitreous hemorrhage. And third, neovascularization not in the disc but elsewhere in the retina, but associated with vitreous hemorrhage. Clear? So this has also been asked the very subsequent year after this question had come. The first year they have asked the high risk characteristic for CRVO, that is neovascularization iris and neovascular glaucoma. The very next year they asked the high risk characteristic for diabetic retinopathy, that is neovascularization disc covering the disc around 1/3 area, or a less severe neovascularization with vitreous hemorrhage, or a neovascularization elsewhere with vitreous hemorrhage. Clear? So this also been asked. This is a neovascular glaucoma picture. You can see new blood vessels which is bleeding, and this blood is collected in the anterior chamber. That is neovascular glaucoma. Again here only neovascularization of the iris, but no bleeding or no glaucoma, but only NDI. It's not, picture is not very clear actually. This is a gonioscopic picture to show, but this light probably you may not be able to identify. Neovascularization of the angle. So the only indication for PRP laser is in CRVO is neovascularization of the iris or the angle to prevent neovascular glaucoma. But if the glaucoma is already come, then that is also an indication. Okay? So if you get only ND, neovascularization of the iris, you may get only as the answer as NDI. They may not give you all full words. So the only indication for laser photocoagulation in CRVO is you are ablating the retina. Pan-retinal photocoagulation in CRVO is neovascularization of the iris to prevent neovascular glaucoma. But if glaucoma has already come, still it is also an indication. Which is not true regarding radiation retinopathy. So before this, I will go to the last year, in the very last IMS entrance examination. The cells which are most resistant to radiation in retina is photoreceptors. Yes, that was the last conducted IMS exam. The cells which are most resistant to radiation is photoreceptors. The last year IIM Entrance exam question. Latest question that had come. So, radiation retinopathy is just like diabetic retinopathy. That means it is just like radiation retinopathy is just like diabetic retinopathy. That means patient will be asymptomatic early on. Patient will not have any symptoms. Fundus is just like diabetic retinopathy. What is the treatment of diabetic retinopathy? Pan-retinal photocoagulation. Treatment is pan-retinal photocoagulation. So it's exactly diabetic retinopathy. But the patient does not have diabetes but has undergone radiation. So it is dose dependent. So that is the answer. Clear? Radiation retinopathy, recent years 2 questions have come. This and the last aims. The layer which is most resistant to radiation, that is photoreceptors. I will go into more important questions. These are very simple questions, so I will go to more important. Which is not true about pregnancy. Diabetic retinopathy worsens, thyroid ophthalmopathy worsens, pituitary adenoma may first present with field defects, uveal melanoma may decrease in size. Answer is? Answer is what? Huh? What? D, yeah? D, C. So then I will tell. A textbook called Mudaliar and Menon, no, last few chapters are diabetes complicating pregnancy, thyroid complicating pregnancy, the pituitary complicating. That chapters would not have occurred if there was no problem. That means diabetic retinopathy will worsen. Pituitary disorders will get worsen, thyroid disorders will get worsen, all endocrinological disorders will get worsen in pregnancy. And the pituitary adenoma may first present with field defect in pregnancy. Correct? The pregnancy is a stage where the pigmentation increases. A fair lady become more dark, a darker lady become more darker. It will not spare a melanoma also. If a small pigmented lesion is there, it will become more pigmented. So uveal melanomas will definitely increase in size because of the increased muscle secretion. Okay? All the point is, all the endocrinological disorders will worsen in pregnancy. So if there is an iris melanoma or any melanoma, the body, that will get worsened. So this will bring us to the other very favorite question area, that is retinopathy of prematurity. Take down, otherwise you will not be able to answer these questions. Retinopathy of prematurity is, listen to me, then you can take down. See, when a full-term baby is born, the retinal vessels will reach the nasal retina, even the periphery of the nasal retina. But the temporal retina is slightly far off. It will not reach the entire retinal periphery. Only 1 month after birth, the vessels will reach the entire retinal periphery. Clear? In a full-term baby. Imagine a preterm baby is born. It may not have reached the nasal retina also. Clear? Now a preterm baby is born, the child has got respiratory problems, you put the patient on resuscitation or ventilator, or you give oxygen, either of these. Immediately when you give oxygen, what will happen to blood vessels? It will go for constriction. So already there is no blood vessels. Now by giving oxygen, blood vessels will again constrict. So when there is a stage of hypoxia, which is aggravated by your oxygen. So what the body will do? VEGF will be released, new blood vessels will come. Clear? Now the pediatrician or the neonatologist is very, very happy. I have saved a child born at 26 weeks with 820 grams. And after that the child will come to the ambient there, where the concentration of oxygen is less. What will happen to these blood vessels? These blood vessels will dilate. These are very fragile vessels. The heart will pump,
It will bleed. What will happen to the blood? Blood will get organized. What will happen to the retina? It will traction retina. It will come and occupy behind the lens as a white. Retina will come and will become like a rounded thing, globular thing behind the retina, behind the lens, and that is called retrolendal fibroplasia, the other name for retinopathy of prematurity. Okay, so this is what is exactly retinopathy of prematurity. So what type of kids will develop this? When premature baby is less than 32 weeks. Babies which are born before, just listen to me, then you can write. Babies born before 32 weeks. Babies who have birth weight of less than 1.5 kg. Babies who have been given oxygen because of respiratory distress, or similar situation is produced by an abruptio placenta. Whenever abruption is also there, it's like less oxygen to the baby. Or when there is maternal malnutrition, maternal anemia. You understood? An intraventricular hemorrhage into the, when the baby is born, there is, subsequently when you take a CT scan, there is an intraventricular hemorrhage. That means there is intraventricular hemorrhage is a feature of hypoglycemia, neonatal hypoglycemia, neonatal septicemia, neonatal hyperbilirubinemia. All these will predispose the child to retinopathy of prematurity. Clear? The low birth weight of less than, now you can take note. The risk factors include a low birth weight of less than 1.5 kgs, premature, that means premature before 32 weeks, gestation age of only 32 weeks, supplemental oxygen, maternal anemia, abruptio placenta, neonatal hypoglycemia, neonatal hyperbilirubinemia, respiratory distress, and intraventricular hemorrhage. Okay, I repeat, the risk factors are prematurity, that is less than 32 weeks, gestation less than 32 weeks, birth weight of less than 1.5 kg, supplemental oxygen, maternal anemia, maternal malnutrition, maternal anemia, abruptio placenta, neonatal hypoglycemia, neonatal hyperbilirubinemia, neonatal septicemia, then intraventricular hemorrhage, respiratory distress syndrome. All these are risk factors for the child. In our retinopathy of prematurity, there is something called plus disease. That was this, not last year aims, the previous year aims question. Plus disease means what? When you put something and put plus means? Very severe disease. Plus disease means such findings which I told you, the neovascularization developing on the center of the retina. The vessels are dilated, everything is occurring in the center of the retina instead of the periphery. You understood? It is occurring in the macular area. It is occurring in the very significant, very important area, that is the center of the retina. Plus disease means center part of the eye, central retina is involved. There is dilatation and tortuosity of the vessels in the central retina, and it's the most severe form of ROP. Plus disease is the most severe form of the ROP. So now you answer this question. All. It's a very favorite question area, retinopathy of prematurity. Plus disease, I will not discuss. I already told you everything about plus disease. You can see these pictures are taken with something called a pentacam. See this. This dilatation and tortuosity is affecting on the central part of the retina. It is a plus disease. And here I told you, this is a red retina, this is a bluish retina. This is what I told you. The vascularization has reached here, but not here. Clear? So, if we expose the baby to oxygen, vessel will go for constriction, new blood vessels come here and will start bleeding. But once if you locate the child, once you find out that this much area is, having no blood supply, what will you do? You just ablate these areas either with laser or cryotherapy, then no VEGF. You understood? Like diabetes,
This area is not vascularized. So this is the cause of VEGF. So the treatment of retinopathy of prematurity is retinal photocoagulation or cryotherapy. Cryotherapy or retinal photocoagulation. Okay. So with this, so I have told you almost all MCQs from ROP. The gestational age is an MCQ. The birth weight is an MCQ. Other associated risk factors, they are also MCQs. Plus disease. Plus disease means more severe form and affecting the central retina. Then we will go to another very, multiple times asked exam question for AIMS. That is, you may not have heard about this condition. It is called ocular ischemic syndrome. Ocular ischemic syndrome. This question have not appeared in any of the state entrance exam, but have been repeatedly asked for AIMS. Ocular ischemic syndrome. You just listen to me. Whatever may be the eye condition, when some retinopathy, what will happen? There will be dilatation of the vessel, there will be tortuosity of the vessels. Clear? In CRV you take, there will be hemorrhages, there will be dilatation of the veins, and there will be tortuous veins. This is the only condition where there is venous dilatation without tortuosity. But because of that particular feature it has been asked. It's only retinal disease where there is venous dilatation without tortuosity. So it is the most common cause of ocular ischemic syndrome is carotid atherosclerosis. Carotid atherosclerosis. Patient will present with intense pain. Intense pain in the eyes on examination. There will be corneal edema, anterior chamber cells and flare, rubiosis iridis, rubiosis of the iris, rubiosis iridis, and cataract. So this is a condition where the carotid blood supply to the eye is reduced. So what will happen? There is less blood supply to the eye. So that is producing the corneal edema, that is producing the anterior chamber cells and flare, that is producing cataract. And when looking at the fundus, you will have venous dilatation without tortuosity. Why? Because there is less oxygen, so the vein is going for dilatation. Blood vessel is going for dilatation. You understood? So it is a common question for AIMS. Multiple times they have asked this question. It is a more specific sign of ocular ischemic syndrome is venous dilatation without tortuosity. All other diseases, retinal diseases, will produce venous dilatation along with tortuosity, but this is the only condition where venous dilatation without tortuosity. It is due to carotid atherosclerosis. The other MCQ that has been asked from ocular ischemic syndrome is this for AIMS. What is the 5-year mortality for central retinal artery occlusion? This is almost double. Nearly 50% of the patients who have developed ocular ischemic syndrome will die in the next 5 years. So it is more than double of CRA. Okay? So it is a significant mortality indicator. So 50% of these patients will have heart disease, ISD, and 25% will have a previous stroke. Ocular ischemic syndrome patients may have cardiac disorder in 50% cases, and stroke in 25% cases, and 50% of these patients will die in the next 5 years. So these are the two MCQ that they have asked from ocular ischemic syndrome. Again, a multiple times asked question for our state entrance exam. cherry red spot. Yes, it is, all others are congenital causes. Niemann peak, Tay-Sachs, gangliosidosis, commissurately or Berlin's edema is due to trauma. The other causes for occurred ones are CRIO, canine toxicity, which is not seen nowadays, and CRIO. There was once a CMC question. The question goes like this. A child was admitted in the ICU with history of seizures. On examination in the ICU, there is something making muscle twitches. Muscle twitches. There's twitching of the muscles. Fundus examination showed a cherry red spot. The likely diagnosis in this condition is correct, somebody told. Now what is it? It is gangliosidosis. It's called cherry red spot myoclonic jerk. These pictures are myoclonus. Okay? These are myoclonus. So cherry red spot myoclonic syndrome, which is a feature of gangliosidosis. This was a CMC question. Myoclonic jerks with cherry red spot. Myoclonic jerk with cherry red spot. That is gangliosidosis. So I will not discuss this question anymore. Answer is what? Answer is NBI is a high risk characteristic for CRVO. All others are high risk characteristic for that. I just wanted to show you these are fine vessels over the disc. This is called NVD, neovascularization of the disc. It is bleeding now from the disc. This is neovascularization elsewhere. Some other area is not on the disc, but some other areas for neovascularization. This is just to show you. This is a neovascularization area. Fluorescent angiogram shows there is leakage from that neovascular area. Normally, see, these are the black area, that is no blood supply there. So that is why the new blood vessels appear. Here you are seeing white areas, that is normal. But here you see black area, that is no blood supply. That is why neovascularization is developing there. This is a fluorescent angiographic picture. Here again a neovascularization that is bleeding. Again a neovascularization that bleeding. You can see white mark. What is this mark? Panretinal photocoagulation mark. Laser mark. Again laser mark. So NBI is a high risk characteristic for CRVO, while in neovascular iris is not a high risk characteristic necessitating laser treatment diabetic retinopathy. There are so many, three others. Again, the year last, not the last year, before that it was asked. Which is not true regarding diabetic retinopathy with vitreous hemorrhage. This is proliferative diabetic retinopathy. Yes or no? Yes. It requires photocoagulation. Yes. Risk of neovascular glaucoma is high. Yes. If on aspirin it has to be stopped. Oh yes, that yes, strength has come down. No. There is only situation where if the patient taking aspirin for some other reasons, it can very well be continued. It cannot increase the vitreous hemorrhage. That is why this question was asked. The patient is on aspirin, it can very well be continued. Okay? Aspirin taken for other purposes should be continued. So this brings us to another favorite area. We have covered hypertension, diabetes, ROP, retinopathy of prematurity, RP, retinitis pigmentosa, and retinoblastoma. This brings us to another favorite area, that is lasers. Lasers is a favorite area because laser was first used in medicine and ophthalmology, and it's now getting into other specialities like dermatology, getting into the general surgery, gynecology, everywhere. So lasers, so many questions has been asked about lasers, about its wavelength, its mechanism of action, its uses, all these have been asked. So before we proceed, I mean, it's very difficult to remember. I agree, very difficult to remember the wavelength, very difficult, that laser, this is what is the mechanism of action, this, what is the mechanism of use of this, very difficult to remember. Before we discuss on it, I will tell you a small story. I think now people are active. See, I have no political interest, but I have gone to one of the most politically labile areas in Kerala, that is even now also Talassery. I was having lunch with, a dinner with one of my friends. His mother was actually a doctor serving food. So it was around 9 o'clock, maybe 9:30. Then suddenly one sound heard. Then I was shocked actually, but they were very casual. Then I asked why this sound. Then his mother told, "Adu on the bomba." Then I thought, what she is telling about. Then I asked, "Madam, what is this?" Then she told, "That is CPM bomb." And she continued serving. I was upset. Well, they are not worried. So I thought maybe like that. She told so many sounds will be, similar sounds will be heard, once in a while. So we just continued to have dinner. Towards the end of the, then I asked him, "Madam, what, this bomb must have blasted?" No, she told it's a bomb. Then I asked her, "Must have been blasted somewhere? Somebody must have been, injured, no?" Then she told me one sentence, "No, nothing must have happened. Today, if you go around that area, you will see where that bomb has fallen down, and that area you must have seen that where bomb has fallen down, there must have been a hole there, a kuli," he told, "a kuli there. That means an otta there." Okay? We continued to have dinner, and towards the end of this, again another sound, and then, "Idu on the bomb tanne." Her expression was different. Then I asked her, "What, madam?" "This is a BJP bomb." From her expression only, I understood something must have been gone wrong. Then I asked, "Madam," when she told, "This must have, if this must have exploded while bomb making, or maybe otherwise also," he told, "it must have if it has exploded in somebody's hands, it must have really burnt or charred or coagulated that person's hand." Okay? This is story she told. Okay. See, I am telling you, I have no political bias. So now you just remember one laser, that is ND YAG laser. ND YAG laser, which has got a wavelength of 1064 nanometers. Just take down. nanometers. It has got a wavelength of 1060. ND YAG laser has got a wavelength of 1064 nanometers. So when the wavelength decreases, what will happen? The frequency increases. Clear? Wavelength decrease means frequency increase. When frequency increase means more energy. That much also is clear? Yes. So ND YAG laser with a wavelength of 1064 nanometers is like a CPM bomb. What madam told? Tomorrow if you go there and examine that area, then you will see wherever it has fallen down, there must be an otta there. So what she meant was, the bomb must have fallen down, disrupted that area, and must have produced an otta there. So the physical property of ND YAG laser is photo-disruption, and its use is capsulotomy or niridotomy. Okay? The physical property is photo-disruption, and its use is an iridotomy or a hyalodotomy. Or a capsulotomy. Iridotomy or capsulotomy. See, all these three facts about Nd:YAG laser has been asked. Its wavelength has been asked, its physical property has been asked, its use has been asked. Next is about, now the laser which is most commonly used for retinal photocoagulation is double frequency YAG laser, DF YAG laser. So I told you the wavelength of YAG laser is 1064. So what is the wavelength of double frequency YAG laser? 532 nanometers. Very simple. Now what madam told? She told if it must have exploded in the hands, it would have really charred, burned or coagulated that patient's hand, that person's hand. So its physical property is photocoagulation, and that is why its use is retinal photocoagulation. Clear? So the other lasers which are used for retinal photocoagulation are argon laser, which is also have a wavelength of around 532 nanometers. I told you, so its physical property is photocoagulation and uses and retinal photocoagulation. I told you when the wavelength decreases, the frequency increases, and the energy increases. Now, if you further reduce the frequency, what will happen? You become more energy. There will be more energy. Okay. So if the energy increases more, you can just use to cut or excise or ablate the tissues. So this is used to cut or excise or ablate the cornea, used to do LASIK, and the laser is called excimer laser, and the property is photoablation. Clear? So when the laser increases, frequency increases, that means the wavelength decreases, it can be just used as a blade to cut or excise or ablate the cornea to correct refractive errors. And that is called excimer laser, used to do LASIK, and the physical properties photoablation. Clear? The wavelength of which is many times asked is 193.3 nanometers. The wavelength of excimer laser is used to do LASIK is 193.3 nanometers. And krypton red is the laser which travels through blood. Krypton, the name itself has got a red. It is the laser which travels through blood. Other lasers cannot travel through blood, but krypton red travels through blood. So, Nd:YAG laser has got a wavelength of 1064 nanometers. The physical properties photodisruption, use is iridotomy or capsulotomy, while double frequency YAG laser physical properties photocoagulation, used for pan-retinal photocoagulation. The wavelength is 530 nanometers. Another laser is used for retinal photocoagulation is argon laser, has got again 532 nanometers. Then excimer laser, which has got wavelength 193.3 nanometers, used to do LASIK, and krypton red is the laser which travels through blood. This has completed all the questions that has been asked from laser in ophthalmology. Which is not true regarding central serous retinopathy? Very simple question. This is our state entrance question. Answer is? Talk loudly. Yes. It is a disease of male type A personality and produce hypermetropic refractive. It is nothing but behind the macula, fluid get accumulated. So that part of the retina only detaches. So normally the rays were falling on the retina. Now, because the fluid is accumulated behind the retina, retina has come little forward. So the image is falling behind the retina. So the refractive error is hypermetropia, correct? Yes. So CSR produces hypermetropia. And majority, 80% of this disease spontaneously resolves in the first attack. 80% of the CSR spontaneously resolves in the first attack. In 4 months' time, 80% of CSR spontaneously resolves in the first attack in 4 months' time. Pictures may not be clear because the light. The indication for laser photocoagulation in CSR include all the following except. Yes, it's a disease of young males. So the answer is elderly. So all others are indication for laser photocoagulation in CSR. Now this question has been asked many times. The most common fluorescent angiographic finding in CSR is ink blotch. Any other answer? More beautiful things are there. Yes, the answer is ink blotch. But majority students will go wrong in this question because smokestack is a beautiful appearance. You must have tractors which is running with a smokestack there. The smoke will come, will go up little distance and spread like a mushroom. In fluorescent angiogram when you take, it's a very beautiful appearance. But the answer is not. I told you beautiful things are deceptive. Ink blot is the most common fluorescent angiographic finding. But in a PGA entrance exam question they asked how many percentage of the fluorescent angiographic findings in CSR is smokestack. It's very less. It's only 7%. 7% only is smokestack. So this particular patient has got both the features. See, this is a stalk coming up, then it is going to spread out. This is a smokestack appearance, but here is an ink blot appearance. This patient has got both. But the most common finding is this one, that is the ink blot appearance. Smokestack is a very rare finding. You can see here also ink blot with the CSR getting stained. You can see a mark, no? This is the area of serous detachment and the retinal detachment there. The fluid is getting stained. What is this investigation? What is this? What's this? Let me get pictures on this. This is called an optical coherence tomography. OCT. And this is a very recent investigation. Optical coherence tomography. This is the advantage of this is you can see this is a very old machine photograph. The latest machines you can identify all the layers of the retina. Individual cells can be identified without taking histopathology. So now it's there only in ophthalmology. If it can replace it with the innovations of the improvement of the machines, it can probably cannot replace histology or histopathology, but can be equally good. So here you can see a red line which is going like this, an area which is going, a line which is going like this. That is the retinal pigment epithelium. There is a collection of fluid between the retinal pigment epithelium and other layers of the retina in the fovea. You can see the foveal depression there. Can you see? You must have read the foveal depression. There is actually a depression there. This is a foveal depression. Between the retinal pigment epithelium and the other layers of the retina, there is a collection of fluid. And so this is single serous retinopathy. And this investigation is CSR. And this investigation is OCT. Alright, in the choice that they gave, there were two other questions, that is lacy filling pattern and cartwheel pattern on FFA. These are the features of choroidal neovascular membrane in a disease called age-related macular degeneration. They have not asked you, but since they have given this as choice, they may ask you in subsequent years. Lacy filling pattern or cartwheel pattern on fluorescent angiogram are features of choroidal neovascular membrane in a disease called age-related macular degeneration. ARMD, age-related macular degeneration. So many times they have asked the fluorescent angiographic finding of CSR. Okay, with that we will move away from retinal diseases, go into another area which is strabismus. We will start with one of the most commonly asked question for our state entrance exam, that is, the lost muscle in squint surgery is. Yes? Many times asked question. Our state Kerala entrance exam. Lost, that means muscle is lost. It is? Which is? You have seen squint surgery. So the medial rectus muscle, no, it's a very strong muscle. After cutting out from the in the eye, it has to be attached somewhere. In between it is held in a forceps. What happens when the muscle has got extensive contractile properties? It will just contract, slip away from the muscle in the forceps, and before you could even think to bring it back, it will retract behind the globe and go and sit at the orbital apex. From there it cannot be retrieved. And if you take an MRI, the patient will see a ball-like thing on the orbital apex. So the patient had come with a small squint and had come for a correction, and you are leaving him with a very large squint. So that is a problem with medial rectus. So this particular question has been asked in so many varied ways, and you see this how it has been asked. I have not put it. Lost muscle in squint surgery, it is called the surgeon's graveyard muscle in squint surgery. It has also been asked as a slipped muscle in SLIPP, surgeon's graveyard muscle, slipped muscle, lost muscle. 3 ways this question, same question has been asked. So we will go into another favorite question area, that is Duane's retraction syndrome. Duane's syndrome. The Duane syndrome, you listen to me, you probably may not be knowing, so you just listen to me and then you will solve this. Duane syndrome is a limitation of abduction. That means it can mimic which palsy? Lateral rectus palsy. So the patient may look like lateral rectus palsy. Correct? So what will be the position of the patient? Eye adducted and what type of squint? Convergent squint. And that is exactly the 2010 AIMS question. What will be the position of the eye in Duane's retraction syndrome? The choices were I will be orthophoric, that means straight. I will be convergent, that is esotropia. I will be divergent, that is exotropia. And any of this is possible. Most common position. Yes, I told you this is a limitation of abduction. So the position of the eye is, I will be orthophoric in majority of the cases. That was exactly why this question of 2010 AIMS question came. The position of the eye in Duane's retraction syndrome. It is orthophoria. It is a limitation of abduction, but I will be orthophoric. I will be straight in majority of the cases. So it is a congenital problem, correct? So congenital problems are more common in males or females? What doubt? Females. So by some unknown mechanisms, all the congenital anomalies are common in one side of the body. Which side? It's common on the left side of the body. Majority. So I told you it is a limitation of abduction, but the eye may be or eye may be straight. So now will come what will happen. So it is a limitation of abduction. If I have got tight divans, means there will be a limitation of abduction. Whenever I try to adduct or may look into left side, if I have limitation of abduction, my lateral rectus is weak like that. Whenever I look into left side, what will happen now? The eyeball will just go back and the palpebral aperture will close. Clear? You understood? There is a limitation of abduction, but whenever I try to adduct, that means I look to this side, you can see the eyeball will retract back and the palpebral aperture will close. This is because a co-contraction by the medial and lateral rectus will pull the eye back. The lateral rectus, which should be supplied by sixth nerve, is now supplied by third nerve. Simple. The nerve which supplies the medial rectus also supplies the lateral rectus. So whenever medial rectus is put into action, lateral rectus also contracts and eyeball moves backward and the palpebral aperture closes down. Clear? So that is the other feature of divan. Any doubt? Clear. Any doubt? Yes. Now, whenever I try to adduct, you can also see the eyeball retracting and palpebral aperture narrows. Also, you can see suddenly the eyeball moves up or down. That is an upshoot or downshoot. Probably because the third nerve which supplies the medial rectus also supplies the superior oblique, which should be supplied by ortho. Clear? So, Duane syndrome is a limitation of abduction, but the eye will be orthophoric in majority of the cases. On attempted adduction, the eyeball retracts and the palpebral aperture closes down because of the co-contraction of the lateral and medial rectus. On attempted adduction, eyeball either jumps up or down because of the co-innervation of medial rectus with superior or inferior oblique. Clear? So this has been many times asked. Duane syndrome. It is associated with, that is again a features of, it is associated with spina bifida. Spina bifida. It is associated with spina bifida. It is associated with keratoconus. It is associated with the deafness. And when it is associated with deafness, it is called Wilder-Wank syndrome. Wilder-Wank. Wilder-Wank syndrome. Wilder-Wank. Some people use B and W. Some people use Wilder-Wank. Either way, it's Wilder-Wank syndrome. Wilder-Wank. Wilder-Wank syndrome when there is associated deafness. And also it is associated with congenital lymphangiectasia. Congenital lymphangiectasia. That is called Klippel Field anomaly. Congenital lymphangiectasia. That is called Klippel Field anomaly. Klippel-Fiel. There are so many other things. Klippel, don't get confused. This is a Klippel Field anomaly. So congenital lymphangiectasia with syndrome. So it's limitation of abduction. It may be an attempted reduction. There is retraction of the globe and closure of the palpebral aperture. On attempted reduction, there may be an upshoot or a downshoot, and eye may be orthophoric in majority of the cases. It is associated with the spina bifida, keratoconus, deafness. When it is associated with deafness, it is called Wilder-Wank syndrome, and may be associated with congenital lymphangiectasia when that is called Klippel Field anomaly. I have left, if I have time later, then I will come back to all other questions they have missed. But now, for the time being, I will go into more important questions. Which of the following drug does not produce optic neuritis or trouble bar neuritis? Had the question been, which of the following drug produce trouble bar neuritis or optic neuritis, the answer would have been Sambuterol. Now what is the answer? Answer is? Yes, rifampicin. Rifampicin is the only drug which does not produce optic neuritis or trouble bar neuritis. So whenever you put a patient on rifampicin without a Sambuterol, other drugs without a Sambuterol, still the patient develops decreased vision, you still have to be suspicious. All anti-tuberculous drugs can produce optic neuritis or trouble bar neuritis except rifampicin. Many times asked question. All drugs can produce optic neuritis or trouble bar neuritis except rifampicin. The sildenafil citrate can produce glaucoma, cataract, uveitis, central retinal artery occlusion. What is the answer? Answer is glaucoma, uveitis, PRIO, glaucoma, all. It is as simple as that. You take it on the previous day, enjoy, next day get up with no vision. That is bilateral venous occlusion, central artery occlusion. Not only that, you may even develop MI. So better not take it. So sildenafil citrate can produce. Notorious side effect of sildenafil citrate is vascular occlusions. This will bring us to another favorite question area, that is cross diplopia, uncross diplopia, homonymous diplopia, heteronymous diplopia, which is also very, very confusing. Almost invariably every alternate year you will get question on this in state entrance exam. Cross diplopia, uncross diplopia, homonymous diplopia, heteronymous diplopia, full confusing. We will like to, we will again try to solve this by studying 3 or 4 sentences. The first sentence is, superior muscles of the eye are intorters of the eye. The superior muscles of the eye are intorters of the eye. Intorter, that means turning inwards. The superior muscles of the eye are intorters of the eye. You finish writing? That means what do you mean? Superior rectus and superior oblique are the primary intorter being superior oblique. You add that. Primary intorter being superior oblique. That invariably means that inferior muscles are extorters of the eye. That means inferior rectus and inferior oblique are extorters. The primary extorter being inferior oblique. Don't write it. So superior muscles are the intorters of the eye. That means superior rectus and superior oblique are intorters of the eye. Superior oblique being the primary intorter. But superior rectus has got another action. That is elevation. Similarly, superior oblique has got another action. Depression. So now you are convinced that the two muscles have got 2 actions. Correct? So, but I have told you only one sentence. Superior muscles are the intorters of the eye, superior oblique being the primary intorter. Now the second statement. Superior rectus acts as at abducted position. Superior rectus act as pure elevator at abducted position. And superior oblique act as pure depressor at adducted position. Clear? Superior rectus act as pure elevator at abducted position and superior oblique act as pure depressor at adducted position. Clear? That means even though these two muscles has got two actions in the primary position, when it is at the extreme gaze, superior rectus has got no inverting action, it has got only a elevating action. Similarly, in an adducted position, superior oblique has got no inverting action, it has got only a depressive action. Clear that much? So that invariably means inferior muscle, that means inferior rectus and inferior oblique are extorters of the eye, inferior oblique being the primary extorter, and at abducted position, inferior rectus has got only a depressive function, and at adducted position, inferior oblique has got only a elevating function. Clear? Any doubt? No doubt. And the third statement, oblique muscles are also abductors of the eye. Oblique muscles. Oblique muscles are also abductors of the eye. That means superior oblique and inferior oblique are also abductors of the eye. But we know there is an abductor. What is that? Lateral rectus. That we know. So that is why I didn't make you right. But oblique muscles are also abductors of the eye. Clear? So there are three statements we have told. Superior muscles are the intorters of the eye, superior oblique being the primary intorter. Second statement I told, superior rectus as a pure elevator at the abducted position and superior oblique act as a pure depressor at adducted position. The statement, third statement I told you is oblique muscles are also abductors of the eye. And the fourth statement I am telling you is when the eye is crossed, when the eye is crossed, diplopia is uncrossed. When the eye is crossed, diplopia is uncrossed, and uncrossed diplopia is called homonymous diplopia. The eye is crossed, diplopia is uncrossed, and uncrossed diplopia is called homonymous diplopia. Clear? This much you are clear? You just go through whatever I have told you, that 4 sentences. You just listen, you just go through it. What is your lunch break? What time? 1 o'clock. Huh? What time is the lunch break? Huh? 1 o'clock. 1:32? If you can come back within 10 minutes, I can go through more questions. Because I will stop at 3:30 exactly, because I have a train at 4:20. So I have to go up to Madurai. So there's a direct train for me here to 2:30. If you can come back by, 10 minutes lunch and then come back, I can. Lunch will be served here, no? You have to go out, huh? Okay. Huh? I don't mind taking till 3:30. Then we will continue. Okay? Because I will come only once more. Class which may be up to 5 o'clock or maybe 3:30. I don't know. It depends upon it. I have to reach there. That's the problem. There is a summer train which is there today, which goes up to Madurai, so I don't have to go. Otherwise, I have to go to Trichur. From there, I have to catch Guruvayur Madurai, Chennai. There's no other train which goes to Madurai from here direct. So anyway, let me leave it. So you have gone through this sentence, and the last sentence which I have told is when the eye is crossed, diplopia is uncrossed, and uncrossed diplopia is homonymous diplopia. Now, look at me. Suppose I have got lateral rectus palsy. What is the position of my eye? Convergent. That means what? That means suppose I have got right lateral rectus palsy, my eye is in a convergent position. That means this eye is going to cross the other eye. Clear? So what is my diplopia? Uncrossed diplopia. So it is called homonymous diplopia.
So in palsy of lateral rectus muscle, the diplopia is uncrossed diplopia, and it's called homonymous. Any doubt? You understood? Any doubt? Because this question will be repeatedly asked. Suppose I have a lateral rectus palsy, I will have a convergent squint. Clear? That means my right eye is going to cross my left eye. Clear? Because the convergent squint. So eye is in a position of crossing. So my diplopia will be uncrossed. And I will have a homonymous diplopia. We should not go into any details of what is uncrossed. This is only for entrance. Entrance test. When the eye is crossed, diplopia is uncrossed. So the answer is uncrossed diplopia is seen in the palsy of all except because lateral rectus palsy there is convergent position. I also told oblique muscles are also abductors to the eye. So in oblique palsy also you can get the eye in a position of crossing. So diplopia is uncrossed. So such questions will come. I will not go into any other details again. It will come like this. So non-homonymous diplopia, that means crossed diplopia. So you have to just analyze what muscle. So I have just told the fact behind these questions. Now you have to analyze this and answer. Okay? Everybody understood, no? Yes, okay. Now with that we will go into another area, that is paralytic squint. See, I can continue up to 3:30, no? There should be full support. I should not, press people to learn. So, all are features of paralytic squint, except just imagine, till yesterday I had no squint. Suddenly today I developed lateral rectus palsy. What will happen? You must have seen patients in ward, no? Lateral rectus palsy patients. So what will happen? There will be diplopia. Clear? So that is there. So diplopia is a feature of paralytic squint. So this patient, when he looks straight ahead, he will have diplopia. Clear? He cannot look to this side. When he looks to this eye will not move, but this eye will move. Clear? Suppose I have got right lateral rectus palsy, I want to look to my right side. This eye will not move, or very little only will move, but this eye medial adduction will occur. So this eye will not move, this eye will move. So there will be two images, diplopia. Correct? So patient cannot walk like with diplopia. The muscle is not working. What the patient will do? He will turn the face and see like this. So he will walk around with a head posture like this. Suppose I have got a right lateral rectus palsy, I will have a head posture like this. I will walk this. So the eye is not at all coming into the field of action of the lateral rectus. Clear? So if I have got a right lateral rectus palsy, I will have a face turn to the right side. This much is clear. That means, in other words, for entrance exam, you just remember, if my muscle is not working, my head will work, I will just turn to that side. If I got left lateral rectus palsy, my head turn to be towards the left side. Or a head turn or a face turn towards the left side. So definitely there will be a abnormal head posture. Then about this problem of primary deviation, secondary deviation. You must have seen so many people who are squint, but with straight, they will be very beautiful except the squint. They will be walking straight. That means it is not a paralytic squint. The patient, somebody is having, squint, but no abnormal head posture. They are aram se walking. They are not complaining of diplopia. That means it is not a paralytic squint. That means that such type of squints are called concomitant squints. Concomitant squints. C-O-N-M-I-T-A-N-T. Concomitant squint. C-O-N-C-O concomitant M-I-T-A-N-T. Concomitant squint. So somebody is having squint, you will be daily seeing patients, people now with squint, they will be very beautiful except that squint and they will be walking around, no complaint of diplopia, no head posture, nothing. That means you make a diagnosis of concomitant squint. But you see some patients who is complaining of diplopia with walking around like this, that means there is paralytic squint. So suppose, I have got concomitant squint, I have no diplopia, my head posture is right, and when somebody puts torch, I have got an exotropia. So somebody shines torch into my eye, the reflex is falling on the center of the pupil in my left eye and is falling on the pupillary margin of the temporal pupillary margin, it is 15 degrees, and is falling on the between the pupillary margin and limbus it is 30 degrees, and it is falling on the limbus it is 45 degrees of convergent squint. Clear? If it is falling on the nasal pupillary margin, that means my eye is diverted out, it is 15 degrees, and if it is falling between the nasal pupillary margin and the limbus, it is 30 degrees of exotropia or divergent squint, or if it is falling on the nasal limbus, 45 degrees of divergent squint. Clear? So I am going around with, when somebody is shining torch, it is falling on the center of the pupil in this eye and is falling on the nasal limbus of my right eye. So I have got how much degrees of squint? Nasal limbus, 45 degrees of divergent squint. So somebody covers this eye, right eye now, left eye now. And what will happen? This eye will take up fixation now. This eye will take up and look at the lights. When somebody removes the cover, now this eye will be fixing and this eye will be deviating 45 degrees. That is, now falling on the central pupil in this eye and falling on the nasal limbus in this eye. Clear? Clear? So that means previously my this eye was deviated 45 degrees and now my this eye is deviated 45 degrees. Clear? So that means my primary deviation, that is my original deviation when you first saw me, that is 45 degrees. And now you are, after some time, secondarily you saw me, the other eye, that is the secondary deviation, that is also 45 degrees. So when the primary deviation is equal to the secondary deviation, that is concomitant squint. Now you just look at me, don't write please, don't write. Now imagine instead I have a lateral rectus palsy. So when somebody shines torch, imagine I have got a medial rectus palsy, to make it very more simpler. Medial rectus palsy. So when somebody shines torch on my eye, this is falling on the center of the pupil in this eye and this is falling on the nasal limbus. That means I have got 45 degrees of divergence. Now somebody wants to cover this eye and force this eye to take up fixation. The medial rectus will try to make the eye straight. Correct? It is not working and the lateral rectus has pulled it outward. Now the medial rectus, when somebody had covered this eye, it has to look at light, so the medial rectus will try and bring the eye central. So medial rectus, so much innervation will go to the medial rectus to bring it to the central. So an equal amount of innervation will go to the lateral rectus of the other eye. So when the medial rectus is contracting, an equal amount of innervation will go into lateral rectus of the other eye. So when you take out the medial rectus, when you cover, the medial rectus will take a fixation, and once you remove the cover, you will see this eye is now straight, but this eye has deviated so much. So the secondary deviation is more than the primary deviation, that is paralytic squint. But you learn only one thing, that is in concomitant squint, primary deviation is equal to secondary deviation and 2 is always more than 1, that is paralytic. 2 is more than 1, that is paralytic squint. Okay, you are not comprehending it. Yes. Primary deviation is equal to secondary deviation, that is concomitant squint, and 2 is always more than 1. Not 1 more than 2, that is why I told you 2 is always more than 1, that is more than 1, more than, and primary deviation, that is paralytic squint. Clear? So 2 is always more than 1, not is you, because it is a fact. It is there in paralytic squint. But but in the exam you will get confused whether it is primary deviation bigger than secondary deviation. No. 2 is always bigger than 1. Okay. So many such examples are there in medicine. Since time is lacking there, I just not telling, but I will tell you one thing. Where is the nucleus of the first chromosome located? So where is the nucleus of the second now? Where is the nucleus of the third now? Where is the nucleus of the fourth now? Where is the nucleus of the fifth now? But majority. Where is the nucleus of the sixth now? Where is the nucleus of the seventh now? Where is the nucleus of the eighth now? So this is an example like 2 is larger than 1. 2 plus 3 is always equal to 5, but the reverse is not 2. So if you can comprehend what I have told you, you understand it. So 2 is more than 1. The first 2 does not have a nucleus. The next 2 are in. You are still not comprehending. So 2 plus 3 is always equal to 5. So you can still comprehend, I think. That's enough. 2 is more than 1. That is a paralytic squint. See, people ask you where the nucleus. If you know this, the mathematical principle, you can tell where the nucleus exactly is. So I just not going and not entering into that area. I'm just telling you 2 is more than 1. That is paralytic squint. Okay. So when primary deviation is equal to secondary deviation, it is a concomitant squint. The answer to this question is? DS. So this will bring out to another important question, the last year All India question, that is congenital or infantile esotropia. The last year, anybody has written last year All India, you will be knowing there was a question on infantile or a congenital esotropia. You just take down. I just before that you just look at me to understand things. If you understand, then you will not forget. Suppose I have normal vision. When I reach 40 years, I will have difficulty in reading, and that is called presbyopia. So what will happen? My ciliary body will not contract. The tone is lost. So when we want to read normally, what will happen? The ciliary body will contract. So the sonules will relax. The lens will bulge forward. You will be able to read. That is what happens. See, you are looking at a distant object that is focused on the retina. Now when you want to read something naturally, what should happen? The rays should focus behind. No, the object has come close to you, so the image should be back. So you are just preventing it by contracting the ciliary body. So you will relax, the lens will bulge forward, and the rays will be focused on the retina. Clear? Yes. That is what normally everybody will do. So what will happen when the ciliary body will contract? There is something called accommodation. There will be convergence of the visual axis. So normally when everybody reads, there will be little amount of convergence squint. Clear? Imagine a person who is hypermetrop. Hypermetropia means his distant image is falling behind the retina. So for him to read the distant image itself, he has to contract the ciliary body to bring it into the retina. Clear? Suppose imagine he is reading near. The ciliary body has to contract more to bring it into the retina. So what will happen to the eye will be more convergent. So the refractive error producing convergence squint is hypermetropia, and that is called accommodative esotropia. The treatment of which is correction of hypermetropia, that is spectacle. Suppose if somebody does not have hypermetropia and is having convergent squint, and that is called non-accommodative esotropia, and the most common variety is congenital esotropia or infantile esotropia. Just listen, I will repeat again so that you will know. So this congenital or infantile esotropia is not always, it's never been congenital. It develops around 6 months after birth. The mother will tell, at birth I was straight, now the child has got convergence, convergence squint. around 6 months after birth. So immediately what do you think? You think the child may be having hypermetropia. You will do an assessment for refraction whether hypermetropia is there or not. You surprisingly you see there is no refractive error, or there is a very little refractive error. Children will have 4 diopters of hypermetropia even at birth, up to around 7 years. So if it is very large, like 8, 9, 10 plus hypermetropia, then you will label this as accommodative hypermetropia. You will prescribe glass. Here it is hypermetropia is less than 4, around less than 4, or even may not be there. Clear? Then your diagnosis will be non-accommodative esotropia, and it is starting around 6 months. So your diagnosis will be congenital or infantile esotropia. So there is no accommodation hypermetropia, but still the eye will be convergent. So where is the problem? Which is keeping the eye closed? More than everybody can come back to the limited level. Which muscle? The medial rectus muscles are congenitally very, very strong. Clear? So that is a problem. So this patient will not have hypermetropia, and the problem is medial rectus muscle. Clear? So what is the treatment? You weaken the medial rectus bilaterally, both sides you weaken. Because a very large skin, you do surgery, weaken both medial rectus. That is called bilateral medial rectus regression. That exactly was the MCQ in 2000, year before that, the All India. The treatment of choice in congenital or infantile. This child will have gross skin, so much skin, so that he can fix. If you want to ask him to look to this eye will not move. You may think that it is lateral rectus palsy, because this is grossly squinted. With this eye he can see that side, and with this eye he will see this side, and that is called cross fixation. And if you cover one eye of this patient now, you are surprised. You will see both eyes having nystagmus. Clear? And then you also see one eye is at a slightly higher level than the other eye. That is because of the inferior oblique overaction. Inferior oblique muscle is overactive. These are the associated features of infantile esotropia. Cross fixation, you may think it is a lateral rectus palsy. You understood? There is latent nystagmus. When you straight, there will not be any nystagmus. When you cover one eye, you can see both eyes are moving. Nystagmus. These are all features of infantile esotropia. Any doubt now? So the refractive error which produces esotropia is hypermetropia. The treatment, that is called an accommodative esotropia. The treatment of which is spectacles. But in congenital or infantile esotropia, there is no hypermetropia. The problem is a very strong medial rectus. You have to recess or weaken the medial rectus. Clear? So that was the MCQ that was asked. Answer to this is DS. I forgot to tell you in the previous question. Any paralytic squint, you have to wait. It will spontaneously resolve. For example, you must have seen so many diabetic cranial mononeuropathies. Which is the commonest diabetic cranial mononeuropathy? Sixthenopalsy. That means if the words look very difficult, it only means that which is the isolated cranial nerve palsy in diabetes. It is diabetic cranial mononeuropathy. They may ask you like this, but that is lateral rectus palsy. What will you do? Just observe, it will recover. So you have to wait at least 6 months before you do surgery on a paralytic squint. Okay. This will bring us to another favorite question, that is Mobius syndrome. You just take down this. Mobius syndrome is congenital facial diplegia. Congenital facial diplegia. Congenital facial diplegia with bilateral lateral rectus palsy.
Again, not well framed question. The answer is exotropia. You know, congenital facial diplegia means bilateral seventh nerve palsy with bilateral lateral rectus palsy. So there will be a growth skin like congenital or infantile esotropia. So both are involved. So the problem may be a hypoplasia of the sixth and seventh nerve nucleus.
Hypoplasia of the sixth and seventh nerve nucleus. And these patients will have associated tongue muscle hypoplasia. Associated tongue muscle hypoplasia. So they will have a defective suckling. So they will have a growth retardation. They will have tongue muscle hypoplasia, defective suckling, and so a growth retardation. They will have an orthopedic anomaly, many times asked question, orthopedic anomaly called congenital vertical talus. Congenital vertical talus. Which is called? Which is called? Rocker bottom foot. Congenital vertical talus. Rocker bottom foot. So these are the other features of Mobius syndrome. So question number 52, I have gone into areas where repeat questions have come. Congenital nystagmus, all are features of congenital nystagmus except horizontal nystagmus, sleep aggravates it, horizontal nystagmus, even on vertical base fixation decreases it. Forget about this question, but whenever you see some patients with nystagmus, no, especially children, you should be knowing whether it is a congenital one or whether this is pathological, because very, very important. Some neurological diseases will just start, especially brainstem diseases will start only with nystagmus. Especially children are prone to develop brainstem, posterior foci to the brainstem, gliomas. You understood? So whenever you see a child with nystagmus, you should be very, very careful to know whether it is a congenital nystagmus or an acquired nystagmus. If it's a congenital nystagmus, okay, you can just leave the child. If it is congenital, if it is acquired, then problem. So we should know whether it is a congenital nystagmus or not. For that, we should look at the nystagmus. When you look at it, it is beating horizontally. Okay? And it is a jerk or a pendular type of nystagmus. Nystagmus which is beating horizontally is either jerk or a pendulum slowly moving like or a jerk nystagmus. Horizontal, pendular or a jerk nystagmus. It is beating horizontally. Okay? It is beating horizontally. Horizontal, pendular or a jerk nystagmus. Clear? Now you have first examined the patient. You know that there is a nystagmus which is moving horizontally or pendular. Pendular, which is either horizontal, which is either pendular or jerky. Clear? That much we can make out. Then you ask the child to look up. Ask the child to look up. Even when the child look up or down, still it is horizontal. It is still beating horizontally only. Your diagnosis of congenital nystagmus is again confirmed. Clear? A horizontal, pendular or a jerky nystagmus which continues to be horizontal even on vertical gaze. Clear? That is a congenital nystagmus. If it is not congenital, when you ask the patient to look up, instead of beating horizontally, it will beat vertically or other direction. That means you are sure that it is not a congenital nystagmus. And you can ask the child to look at your finger. Now the nystagmus either decreases or stops. Fixation either decreases or stops. And the nystagmus either decreases or stops on fixation. Or the mother will tell you, doctor, this is always moving, but I have seen when the child is sleeping, that time the eyeball seems to be not moving. Otherwise, when the child is awake, eyeball is moving. When the child is sleeping, the eyeball is not moving. That means it's decreased by sleep. It is decreased either by fixation or by sleep. It's a congenital nystagmus. This is not only for your entrance exam, it's of utmost clinical importance. Horizontal nystagmus, horizontal pendular or a jerky nystagmus, which continues to be horizontal even in a vertical gaze, and it is decreased by fixation or by sleep, that is congenital nystagmus. Now answer is sleep aggravated. Head posture in lateral rectus palsy is head turn to the right side. And left lateral rectus palsy? Okay, very good. The word head turn or a face turn, both are same. Face turn, head turn, that words are same. Synonymous. Sadly, this question was asked us only for Kerala entrance exam. But AIMS they have asked this. Head posture in superior oblique palsy. But I told you, don't worry, I told you in the class what I told. Your muscle is not working, so you turn that side. Lateral rectus is not working, right lateral rectus is not working, so I will turn to that side. Left lateral rectus palsy, I will have a turn to the left side. Now imagine superior oblique. Superior oblique is paralyzed. You should know what is the action of superior oblique. Then only we can. No, don't complicate issues. Don't, it should be very simple, it should be very simple and straightforward. What is the other name of this muscle? Yes, very good, very good. Copying muscle which I have used, I think majority of you must have used. When my superior oblique is very active, I can sit straight and copy from this side and from this side. Sure. If my superior oblique is active, I can sit in the straight line with the other person and copy. I can sit in the straight line with the other person, copy from this side. This is because of my either superior oblique is working. See what I have to do, superior oblique. If I want to copy from my right side, my left superior oblique has to push the eye down and copy from there. Clear? From there I have to copy. Suppose my left superior oblique is paralyzed, my eye will not move. The only way I can copy from this is, I have to turn my face here. Face turn to the opposite side. Clear? That only will not serve the purpose. I have to have a chin depression. Clear? That also will not solve the problem. I have to tilt a little bit and then copy. So it's head turn from the opposite side, tilt to the opposite side, and a chin depression. That is lateral rectus palsy. A turn to the opposite side, a tilt to the opposite side, and a chin depression. This is lateral rectus. Clear? Because this question many times asks for AIMS entrance exam. Right, left, they will ask superior oblique. Turn to the opposite side, tilt to the opposite side, and a chin depression. That is superior oblique palsy. Clear? And for state entrance exam, they will ask you lateral rectus palsy. Okay? Both are like that. Only these two muscles will be asked, lateral rectus and superior oblique. These two only will be asked. So another favorite question here is myasthenia gravis. Answer is usually starts in eye muscles, correct or not? Yes, 80% of the myasthenia start in the eye. and 20% remains ocular myasthenia. They are the lucky ones. 80% of myasthenia starts in the eye, 20% of myasthenia remain ocular. They are the lucky myasthenia patients. What is the test that is used to diagnose it? Sorry, Edrophonium is no longer available. Huh? No, the drug which is used to test myasthenia is neostigmine. Neostigmine test is used to diagnose myasthenia now because edrophonium is no longer available. And if you give edrophonium, the onset of action of edrophonium is, it will work within minutes and will last for only less than 5 minutes. So if you give edrophonium, go for a tea and come back and measure, it is not possible. Moreover, as a child you give this and then while the time you calm the child for examination, the effect of edrophonium goes off. Okay? So that is why neostigmine test is the test to diagnose myasthenia. Clear? So, and the people is never involved in myasthenia. That is how you differentiate myasthenia from other things. People will never be involved in myasthenia. Okay? But all other extraocular muscles will be involved, all other muscles will be involved. You may think some other myopathy, some other cranial palsy, but if it is not involved, that is myasthenia. So, we told my neostigmine test is to diagnose it. Suppose if you can demonstrate the orbicularis muscle weakness. How will you demonstrate orbicularis muscle weakness? You ask the patient to close the eye. After some time, the eye opens simultaneously. That means there is orbicularis weakness. Suppose the patient comes with a ptosis, a patient comes with a lateral rectus palsy or medial rectus palsy, some palsy or ptosis, either of may be the presentation of myasthenia, any of this. In such a patient, if you ask the patient to close the eyes tightly and keep it like that, after some time the eye opens spontaneously, that means orbicularis weakness is there. If orbicularis weakness can be demonstrated with any other extraocular muscle palsy, it is 100% diagnostic of myasthenia and no pharmacological testing is necessary. Clear? If orbicularis muscle weakness can be demonstrated with any other orbicularis muscle weakness, any other extraocular muscle weakness, it is 100% diagnostic of myasthenia, and that is, and that no pharmacological testing is necessary. If the patient presents with a patient can present either with a unilateral ptosis or a bilateral ptosis. If bilateral, always asymmetric. One eye will have more ptosis, one eye will have less ptosis. This is the presentation of myasthenia. The patient may present with a unilateral ptosis or a bilateral ptosis. If bilateral, then it is always will be asymmetrical. That means one is more involved, other is less involved. A patient can present with either unilateral ptosis or bilateral ptosis. If bilateral, it always will be asymmetric. The condition mimicking it is Eaton-Lambert syndrome. The differentiating feature is yes, decremental and incremental response in EMG. That is how you differentiate decremental response in myasthenia. That is why you differentiate myasthenia gravis from Eaton-Lambert syndrome. The other conditions which may mimic myasthenia is which are tumors which may mimic myasthenia? Paracellular gliomas. Paracellular gliomas may mimic myasthenia. The most common associated endocrinological anomaly in myasthenia is Question is here. I are not listening question. Most common endocrinological anomaly in myasthenia. I know the answer will come. That is why that question not come. Is Graves disease. Anybody with the myasthenia, immediately you should look at his neck whether there is a thyroid swelling. If it is not there, you should take a thyroid test. Most common endocrinological anomaly in myasthenia gravis is Graves disease or thyroid abnormality. The other associated diseases in myasthenia are you should tell. Pernicious anemia. Autoimmune hepatitis, somebody had already told. Autoimmune hepatitis. SLE or discoid lupus erythematosus, either of this. So these are the other associations of myasthenia. This covers almost all questions on myasthenia gravis. What all are true about myasthenia except? Answer is what? D. When there is fundus pigmentation like RP, like fundus pigmentation, it is another myopathy called CPEO. You must have heard. Chronic progressive external ophthalmoplegia. They will have fundus pigmentation but not myasthenia. CPEO, chronic progressive external ophthalmoplegia. They will have RP like fundus pigmentation. Answer is what? Answer is what? So much we have discussed, you are not able to tell. Yes, C. So you got an additional information from this question that the operation for lateral rectus palsy is Jensen operation. That's all. Nystagmus that occurs in CMJ disorders is, what is CMJ? Corticomedullary, it is corticomedullary or something else? It is a cervical medullary junction anomaly, cervicomedullary junction anomalies, or it's not CP angle is mele, there is something else. At Raman magnum level or what is the lesion? Arnold-Chiari malformation. All are same question. All are same. CMJ disorders, lesion at the Raman magnum level, lesions at the Arnold-Chiari malformation. Is what nystagmus? Downbeats, a very, very commonly asked question. 3 ways this has been asked. On the 3 ways. It is a downbeat nystagmus. So, but I will tell you the most common question that has been asked on botulinum toxin is the mechanism of action of botulinum toxin. Is what? It inhibits the release of acetylcholine. So used for chemodenervation, injection is always to the opposite of the paralyzed muscle. Blocks acetylcholine release used when surgery is contraindicated. Answer is This was the question, 2010 All India. Bilateral, bilateral biliary rectus recession. That is a weakening procedure for medial rectus muscle. The same question which I have showed you. Answer is? There is one question which that everybody knows. Yes. Answer is? Answer is what? DS. I told you one statement. All tumors can occur in as second tumors, including malignant melanoma of the skin. So skin tumors cannot occur. That is the answer. You have to listen what exactly I have told. So all this will help you to answer other questions. You have seen this patient nevus of aorta? Huh? Yes, you must have definitely, all of you must have seen. For those who have not seen, I will tell you, then you will remember that you have seen. You must have seen, especially ladies, with one side of the face black. That is nevus of aorta. That is a nevus. And if you see the conjunctiva, on the sclera, you see so many black. That's actually the conjunctiva, black areas. That is conjunctival nevus. It is oculodermal melanosis. Nevus of aorta is oculodermal melanosis. Oculodermal melanosis. Okay? So what can be the problems with this patient? Can malignant melanoma develop? It's a pigmented cyst, so they can develop. So what other eye disease can they develop? Yes, glaucoma. They can have increased pigmentation of the trabecular muscle. It can develop pigment ring like glaucoma. Okay? So that is the question. You just have to read most common lacrimal gland tumor as pleomorphic adenoma. What is the answer? Huh? You must have, probably you may not have seen lacrimal gland tumor, but you must have definitely seen and salivary gland tumor, parotid gland tumor. What the surgeon will do? Huh? You will go dissect and will remove us totally without rupturing the pseudo capsule for it. Instead that, we can always take a biopsy, take a FNAC. Will you do it? No. Why? It will actually cause, there are people who are doing it, but it will actually cause seeding of the tumor outside the capsule. What will happen to if there is seeding? Through the rupture that you are making in the capsule, through the needle, the tumor cell will come and deposit outside. What will happen if the tumor cell will come and deposit outside? Recurrence. What will happen if there is recurrence? The tumor begetting recurrence, what will happen? Malignant. So, the answer is? Incision biopsy is absolutely contraindicated in salivary gland, that matter, lacrimal gland, that matter in salivary gland tumors also. Clear? Clear? If you at all you want to do a biopsy, it should be excision of the tumor and biopsy. Excision biopsy. So this will bring us into a very, very favorite question area, that is neurocutaneous markers, or what is it otherwise called? Phakomatosis. This is a favorite question area. Questions will come from pathology, questions will come from ophthalmology, questions will come from medicine. What is phacoma means? Phacomatosis. What is phacoma means? Huh? phacoma. Huh? Phacoma means? I am not asking big things. Simple. It's very straightforward. No, deposition, nothing. Phacoma means birthmark. That's all. Birthmark. So neurocutaneous markers or phacomatosis. You have some idea, no? You have some idea about phacomatosis or neurocutaneous markers. So all I will go only concentrated along the MCQ part of phacomatosis. I cannot go into the disease. It's a very interesting area. So all neurocutaneous markers are having inheritance pattern. Except Sturge-Weber syndrome, because this question is there, so you must have read it. So all neurocutaneous markers or phacomatosis has got inheritance pattern except Sturge-Weber syndrome, which has no inheritance pattern. All others are autosomal dominant except ataxia telangiectasia, which is X-linked recessive, or even autosomal recessive can be there, but X-linked recessive. So many MCQs from that two statements. So all neurocutaneous markers have inheritance pattern except Sturge-Weber syndrome. All are autosomal dominant. All others are autosomal dominant except ataxia telangiectasia, which is X-linked recessive or autosomal recessive, either of these. Now we will go into each of these. And the most common varieties are Sturge-Weber syndrome, neurofibromatosis, tuberous sclerosis, or Whipple-Lindau disease, ataxia telangiectasia, and Osler-Rendu-Weber, which is a very minor disease, so we will not discuss on it. You know now Osler-Rendu-Weber disease is like coiled vessels on the nose, on the meninges, etc. It's not a very severe disease, just sometimes produces what? You have not read END also, epistaxis, or sometimes produce seizures. So it's not a very common disease, not a troublesome disease, but others have got significant pathologies. So first we will discuss on Sturge-Weber syndrome. You just listen to me before you write. I will give you enough time because this is a very favorite question area. See, Sturge-Weber syndrome, it has got hemangiomas involving the one side of the face, especially in the first and second division, in the distribution of the first and second divisions of the fifth nerve. It may involve the third division of the fifth nerve. It may involve the upper trunk, or it may involve opposite. Clear? So it is hemangiomas involving the face. It must involve the first and second divisions of the fifth nerve. It may involve the third division of the fifth nerve. It may involve the upper chest. It may cross over to the opposite side. Okay? That's it. This is an important cause of congenital glaucoma or ophthalmos. Important cause of congenital glaucoma or ophthalmos. If there are upper lid lesions, hemangiomas, almost invariably there will be glaucoma. If there are upper lid lesions, almost invariably there will be glaucoma. associated choroidal hemangiomas in 40% of the patients. There will be choroidal hemangiomas in 40% of the patients. So I will just repeat it. This is the only neurocutaneous marker without inheritance pattern. It will have hemangiomas involving the first, it must involve the first and second divisions of the fifth nerve, it may involve the third division of the fifth nerve, it may involve the upper chest, it may cross over to the opposite side. If there are lesions involving the upper lid, then there will almost invariably glaucoma, and it is a common cause of congenital glaucoma or ophthalmos. So that's about the Church-Weber syndrome. It may have choroidal hemangiomas in 40% of the patients. Okay? These patients will have hemangiomas involving the meninges, which will produce seizures. This meninges may get calcified, producing railroad or tram track calcification. This meninges, which is having these hemangiomas, may get calcified, producing railroad calcification or tram track calcification. Okay, so that completes Church-Weber syndrome. Its MCQ has been asked where inheritance pattern, about congenital glaucoma, what will happen if there are lid lesions, and that much I think. I mean, this railroad calcification and tram track calcification has also been asked. Okay, so that will bring us to the next common neurocutaneous marker, that is neurofibromatosis. Neurofibromatosis type 1 is called what? Von Reckling-Hossen's disease. The chromosomal associated with von Reckling-Hossen's disease is 17, long arm, short arm. All, huh? Any other answer? I am happy you did not tell intermediate arm, so you will go back and see. Okay. Oh, okay. So it is the chromosome 17. What is the chromosome associated with the type 2 neurofibromatosis? The 2 is always 2, no confusion. It is double 2, not only 1 2, it's double 2. That is 22. So chromosome 17 and 22. So I cannot go into any of the details, much details of the neurofibromatosis. I will just go into the MCQs of it. In neurofibromatosis, there can be embryonal carcinomas. Embryonal carcinomas, which are lethal tumors. That is a cause of death in neurofibromatosis. This is another condition where you get another tumor. What? Okay, it will come. Another thing. Ophthalmology is yes, where it will come in more on 2. Pheochromocytoma. This is another condition where you get pheochromocytoma. But neurofibromatosis can develop optic nerve glioma, schwannoma, all this. Optic nerve glioma, schwannoma, everything. So since you have told optic nerve glioma, the profile of the patient with optic nerve glioma is boy or a girl, usually a boy, around 10 years with unilateral proptosis. On a boy of around, or a child of around 10 years with a unilateral proptosis, on CT or MRI there will be fusiform swelling in the optic nerve. A fusiform swelling in the optic nerve. A fusiform swelling in the optic nerve with a radiolucent central area. A fusiform swelling with a radiolucent central area, which is the optic nerve within the tumor. A fusiform swelling with a radiolucent center area, which is the optic nerve. A similar swelling in a middle-aged lady. Diagnosis is optic nerve sheath meningioma. Optic nerve sheath meningioma. Similar swelling in a middle-aged lady. Optic nerve sheath meningioma. Okay? So, it's only a age difference for these two tumors. One is in a child, other is in a middle-aged lady. Both will produce, it will involve the optic nerve, it may produce proptosis. But there are subtle differences, we are not going into this. So we will go into neurofibromatosis, tumors you have taught. Okay. Then about type 2 neurofibromatosis. Diagnostic criteria is bilateral acoustic neuroma or unilateral acoustic neuroma with otherwise with schwannoma, optic nerve glioma, or a combined hamartoma of the retina and retinal pigment epithelium, or a posterior subcapsular cataract of the other side. It is bilateral acoustic neuroma or unilateral acoustic neuroma with optic nerve glioma, schwannoma, or a combined hamartoma of the retinal pigment epithelium and retina on the other side, or a posterior subcapsular cataract of the other side. These are the diagnostic features of the type 2 neurofibromatosis. Okay? So this we will enter into the third neurocutaneous marker, that is bone Willis disease, that is tuberous sclerosis, which is otherwise called epiloia, EPILOA, which are the abbreviations of the words epilepsy, low intelligence, and adenoma sebaceum. Epilepsy, low intelligence, and adenoma sebaceum. These are the abbreviations of the word. They will have seizures. And seizures and hydrocephalus in around 40% of the patients. Seizures and hydrocephalus in 40% of the patients. They may have mental retardation. You have seen no patients with tuberous sclerosis. Okay. You will see the striking feature is you will see some skin tags like things on this area, around the nose. If you ask the history, then they will tell the child is not going to school. He is now studying in only first standard. The child may be grown up, but the mother will tell he is going only to first standard. That is, and you ask for a history of seizures, it will be tuberous sclerosis. There are mental retardation, they will epilepsy, hydrocephalus, and they may have endocrine abnormalities. MCDs they will have three important features. Retinal, what will be there? I already told in the morning. Huh? Retinal? What? The benign variant of retinoblastoma? Retinal astrocytoma, which is called mulberry tumor. Mulberry tumor of the retina. So, the other important MCQs from this is the associated anomalies. What are the associated features in tuberous sclerosis? Shash-leaf macules, Shargrin patches. I don't want, everybody will be knowing. I want which is not. Just tell him that we will be continuing up to 3:30 and. Sorry. You can continue or you are. Continuous ആയിട്ട് 3:30 വരെ എടുക്കാൻ പറഞ്ഞു. അത് കഴിഞ്ഞിട്ട് കുട്ടികൾക്കെല്ലാം എവിടെയാണ്? Okay, but they want to continue. അവർക്ക് കണ്ടിന്യൂ ചെയ്യാൻ. അത് കഴിഞ്ഞിട്ട് കഴിക്കാം. So the MCQ that I've asked from this is three things. Atrial myxomas, subungual fibromas, and angiomyolipoma of the kidney. Atrial myxomas, subungual fibromas, and angiomyolipoma of the kidney. These are the features of tuberous sclerosis. Many times asked the same question. Atrial myxomas, angiomyolipoma of the kidney, and subungual fibroma. These are the varieties. Now we will go on to the fourth one, that is von Hippel-Lindau disease. You have any idea? Von Hippel-Lindau disease? Yes. So von Hippel-Lindau disease, the word is very confusing, very big, and you will think about big disease. Nothing, simple. What is that? It is a disease of cyst everywhere. It's a disease of cyst everywhere. Von Hippel-Lindau disease. We are hearing from pathology to medicine to surgery to ophthalmology, but no idea. But now you learn it is a disease, simple disease, the cyst everywhere. Cyst everywhere means cyst in the lung, cyst, yes, listen to me. Cyst in the lung, cyst in the suprarenal, cyst in the kidney, cyst in the pancreas, cyst in the liver, cyst in the epididymis, cyst in the testis. Over. That is von Hippel-Lindau disease. Cyst everywhere, from lung to the testis. Cyst in the lungs, cyst in the liver, cyst in the suprarenal, cyst in the kidney, cyst in the pancreas, cyst in the epididymis, cyst in the testis. Take this break. Yeah. Okay, sir is telling we'll break it for lunch. If you can come back early, I can start early. Or those who want to go for lunch, you can go for lunch and come back. Others who want to stay, or whatever it may be. Up to. Huh?
the character.
Can you just come back in 15 minutes time? If you can come back in 50 as early as possible, I can go through maximum number of questions.